Can I have your attention, please, just for a minute? I want to say thank you to each and everyone that's taken time out to actually come down here this evening. I know everyone's come from work and it's hard and stuff like that, but thank you all so much. And it's good to see so many men here and ladies here as well today. We've got some great speakers that's here, urologists. We've got some doctors and some professors here as well to answer any questions that you have regarding the prostate cancer. Right, my name is Keith Gussy Young. And my cousin Errol McKeller is right here. He'll be talking about a few things as well. And everyone that comes on will be introducing themselves to you. So first of all, I'm going to start from my perspective of having been diagnosed with prostate cancer. 4 years ago, I got a call from my doctor saying to me that he needed to see me. But prior to that, I was having my regular checkups, just normal checkups. But the doctor called me and said to me that they need to actually see me about something else. So I went down and saw him, and he said to me that that they detected a small tumor, that my prostate was high. So he said to be certain, I needed to have a scan to determine how large it was or where it was. So I had the scan. And the scan showed up something on there. And he told me to come back. I went back, and he said to be certain to have the biopsy. So when I went to have the biopsy, there was two guys that was there. And I was speaking to the doctor, and the doctor said to me, he just read out what was going to be happening. And he said to me that I needed to have the biopsy to really determine what was what. So when I said I was going to have it, there was a guy that was standing next to me and said to me, "Oh, you're going to have the biopsy?" So I said, "Yes." He said, normally when people say that to people, they normally get up and just walk out. So he was surprised that I stayed there and wanted it, and actually wanted it. So I had the biopsy, and that determined the tumor. So when the doctor told me that, my heart sunk. So many things was going through my head at the time. And I left the hospital, and I sat in my car for about 45 minutes. And I sat down there. I cried in my car, and I was just thinking about what am I going to do, kind of thing, because I didn't know nothing about it. And I sat there, and the first thing I did was phone this man here. And because I knew that he had gone through this similar kind of things, what I'm going through now. So I explained to him exactly what was happening with me. And he said to me to make sure that I get the right tests done to determine where I go from then onwards. So the first thing I'd done was I spoke to my wife. I told her, and I just felt a voice drop, and then I said to her, "Look, it's fine," because after the 45 minutes, I just tried to get my head right. And I phoned my brother. I said, "Listen, this is what the situation is. You need to go and get yourself tested." So after that now, I was telling a couple of people that I know, and one of them said to me, why do I want to share it? Why do I want to tell people about it? I said, "Listen, it's not just about me." And some people can't really understand that, because it's for me, it hit me hard, and the person I spoke to, I asked him what his PSA levels were, and this man said to me that he doesn't really go to the doctors. He's not really worried about going to the doctors. He's just going through the motions, and he told me that his PSA level was 12.2. So I said to him, "Well, what you doing about it?" He said, "Gus, man, I'm just going through the motions." Now, there's a lot of people out there. You see, I'm really glad that you guys are here now, because the people that I really want to be here are not here. They're not here now. They all know about this, but they're not here today. And slowly, one or two people are coming to me and saying to me, "Gus, who do I need to see?" And this is only because now they're either feeling some pain somewhere or something's happened. But why wait until that situation happens? So this is why we're having meetings like this to try and enlighten men now. It's good to talk. It's, you know, all of us are in the same situation, you know, and as much as, for me personally, my head was just all over the place. But now I'm in the right place now. I've got some great people behind me. Charing Cross, that's where I'm based now. And the advice and all the information that they've given me has been fantastic. Because when you find out, I didn't know anything about it. I started to read up on certain things, but again, I still didn't know enough. I went to 3 places. I went to Northwick Park, I went to Mount Vernon, and then ended up at Charing Cross. And that's where I got all of the information that I needed. You know, and now they put me on active surveillance, going there every 6 months, getting my PSA checked. And now I'm going back there, I'm getting my PSA checked every 3 months now to try and keep it down. But one thing that I've noticed that people are saying to me is that when you reach a certain age, the doctors don't really notify you about the PSA. They just give it a normal blood test. But once you are at a certain age, you are supposed to get that automatically. So that's what we're trying to push for that. So on that note now, I would like to thank all of you really for coming here, because I know some guys are here. It's hard to come here. It's hard to hear certain things. But when you hear from somebody who's gone through the past, what I've gone through, because mine is the early stages. I'm right at the beginning because I got my checks. Okay, so I'm at the early part. But I've known people that's gone on from that, which my cousin's going to tell you about in just a minute. And I know one particular guy now whose relationship has actually broken up because of this. Because his wife thought it was a quick fix thing. So this is why I need ladies to come down to try to understand the emotional parts on the man's side of things, to understand it from his point of view, where to go and what to do. But thank you all for coming here today. Thank you.
So, good evening, ladies and gentlemen. First of all, I want to apologize for being late. I was stuck on the North Circular. You all know how bad that road is. So I'm not going to make any more excuses, but I'm going to share my journey with you, right, before I allow each and every one of you to confront all of these experienced heads that we have here, because what's important about tonight is not just about what Gussy and myself are going to tell you, but the questions you're going to ask these very important people, right? Because let me tell you about this illness, right? Me and prostate cancer, that journey started at the end of 2010, when my wife, Sharon, which a lot of you know, was complaining about my snoring. And before anyone asks, snoring's got nothing to do with prostate cancer, all right? So let's clear that one up. All right, guys? Snoring's got nothing to do with that. Okay, so you got the nod of approval on that. I said to my wife, if this bothers you that much, you make an appointment with the doctor and I'll go. She made the appointment. I went to the doctor, sat down, picked up a leaflet, read the leaflet, and I thought, you know what? While I'm sitting here doing nothing, I'll go and make an appointment to come back and do this test, right? The leaflet I read was information on PSA and testing. So I went to the reception. Young lady said, Mr. McKeller, you don't need an appointment. It's a simple pinprick blood test, and it takes less than 10 minutes. Let me tell you guys, at no point did I ever think that 10 minutes was going to change the rest of my life. Anyway, I did that. Sat back down, waited to see the doctor about the snoring, which took ages, by the way. In the evening, I got home, I sat down, waiting for my dinner, right? And while the wife was cooking the dinner, I said to her, Shah, by the way, while I was waiting to see the doctor about the snoring, I did a blood test for prostate cancer. Well, she stopped cooking immediately. Gentlemen, and you know when these women look at you in that way, that the next thing you say is going to be very critical, yeah? She said, what's that got to do with your snoring? Let me tell you, ladies and gentlemen, the answer I gave her Must have been a good one because I got my dinner that night. A couple of weeks after that, I get a phone call. Mr. McKeller, can you come in to do a blood test? I said, I've just done one with you a couple of weeks ago. They said, yeah, we like to follow up on that first test. I said, okay. So I went in, did the blood test, never thought nothing of it, right? About a month after that, I get a phone call. Mr. McKeller, we've booked you in for a biopsy. When is that? I said. They said, actually, it's today. I said, oh. They said, we have been trying to get in touch with you. We have sent you messages. To be honest, yes, they did send me messages, but I chose to ignore them. And not a good thing to do. Anyway, I took the details, I put the phone down, I rang my wife. I said to her, I've just had a phone call from the doctor. They want me to come in and do a biopsy. When is that, she said. So then I had the painful experience of having to tell her that it's today, and I ignored the messages, and that's why I didn't say anything. So that was a difficult period on that again. Anyway, she said, okay, don't drive, get a cab, and I'll see you at the hospital. Right. And just before I put the phone down, I said, by the way, what's a biopsy? She chose not to tell me what this biopsy was. She said it's a routine thing, nothing for you to worry about. Let me tell you, guys, I applaud every woman in this room because we men are not built for that test, right? Trust me, we're not built for that test. I don't know how women do the things that they do, right? These medical guys will tell you a lot of us men will shy away from doing the biopsy, right? When I got in the room, me and my wife were sitting there. The nurse that came in and sat down and explained to me exactly what she was going to do, right, looked like Rihanna. And please laugh, because I was laughing at the time when I saw her sitting there telling me that she's going to put this thing that looked like a snooker cube in my rear end to take some samples, right? And I thought, okay, this sounds exciting. I just took it on the chin. I couldn't work out why my wife was sitting there laughing, though. Let me tell you guys, when she went out the room, the person that came back in was not the same person that went out the room. I have to tell you, the person that came in was built like a wrestler, right? So you can imagine how painful this next experience is going to be. And I'm not ashamed to tell each and every one of you, I cried. I cried, right? It was very, very uncomfortable. Not something that I would wish on anybody, but very important for these guys to analyze what the state of your prostate is, right? I'm glad to tell you, and these guys will tell you, I think you're phasing that one out, aren't you? So don't worry, guys, you're not going to get Rihanna anymore. Anyway, a couple of weeks after that, I had an MRI scan. A couple of weeks after that MRI scan, they called me and my wife in, sat us down, and they said, Mr. McKeller, your prostate is covered in cancer. And I got to tell you, I got up and I walked out of the room. I went and I sat in my car. And I think the word cancer, that's when it hit me. Right? And listen, when I tell you I cried like a baby. Right? And I thought, I'm going to die here and there's nothing that I can do to prevent it from happening. And my wife came in the car and she sat down with me. And this is why women are very, very important in this conversation that we're going to have, right? She looked at me and she said, all the years I've been with you, I've never seen you quit on anything you've ever done. Ladies and gentlemen, let me tell you, I had to wipe those tears from my eyes. I had to man up, right? And I looked at her and I thought, is she having a go at me, or is this her way of motivating me to get up and do something? I took the latter. I said, come on then, let's go and face the doctor. Right, we went in. I said, doctor, what do I need to do to deal with this problem? He looked at me, he said, Mr. McKeller, if we don't remove your prostate, you will be dead in 6 months. Now, I looked at him, I looked at my wife, and I said to him, well, let's do it then, let's remove it. He said, There will be some issues you'll have to deal with. There'll be some side effects that you'll have to come to terms with. I said, doctor, if I've got a chance of staying alive, I'll take it. I had the operation, but by then, the cancer had already started to travel. So I then had to have 3 months of radiotherapy to burn away the rest of that cancer. That's very uncomfortable, very, very uncomfortable, because although it was successful in removing the rest of the cancer, the side effects is that it's left me with incontinence and erectile dysfunction. But you know what? I'm alive. I'm alive, right? Amen to that. So I said to my wife, I need to find some way of doing something about this problem, because it's God and you and everybody else is the reason that I'm still alive, right? If I have the amount of cancer that they're telling me I have, why am I still here? And my wife looked at me and she said, listen, this cancer only knocked you down. It hasn't knocked you out. So you're going to go 12 rounds with this cancer, but you will take everybody with you on this journey. And that's what I wake up to every morning, right? And thanks to these wonderful people here, but more importantly, you guys and beyond, right? We set up a charity, right? Professor Frank here is one of our trustees. Collectively, since we've done that, we've saved over 1 million lives in this campaign. And I use the word we because one man don't do that by themselves. It's all of us, right? And I was out of work for 6 months. I used to be a mechanic, servicing, repairing, MOT in your cars. When I went back to work, first week I went back to work, a guy walked in. We had a pleasant conversation. He said, you know what, I'm really glad to see you back. I know you were going for a difficult time. And the conversation was fine until I looked at him and I said, when was the last time you had your prostate checked then? And he looked at me. Now, this is a man I've known for years, but he looked at me angrily, like he wanted to have a fight. And then he said to me, what the bleep, bleep, bleep has that got to do with my gearbox not working on my car? Yeah. Let me tell you what happened after that. I looked at him and I said, I tell you what, I'm going to give you 20% discount on the work I'm going to do on your car if you go and get your prostate checked. Not a good idea, by the way. Not a good idea. Right. 2 weeks later, he came back in and he was waving this bit of paper in his hand. And he said, I took your advice and I went and got that check done. And I remember looking at him and I remember looking up there. I said, God, this has just cost me £200. He saw the look on my face and he looked at me and he said, don't worry about the money. I looked up there, I said, thank you, God. He said, but you better read this letter. Let me tell you guys, to this day, I can still remember word for word what that letter said. He had 25% cancer in his prostate. He was the first of 48 guys that walked into my garage in the East End of London that was diagnosed with prostate cancer. Not enlarged, not just a problem with their prostate cancer. So the press got hold of it. They came to the garage. The day they came to the garage, a guy turned up there. He said, listen, 5 times this man gave me a leaflet to go and get myself checked. 5 times I threw it in the bin. The 6th time, I decided to take the leaflet home. And he said to me, you know what my wife said? You're not going to have no sex until you get that test done. That's what she said to him. And when he went and got the test done, they found he had cancer in his prostate. So it always takes something unusual or something different to get diagnosed. And the reason why we're all sitting here tonight, right, is because we need to make this job easier for these guys here, right? There's men out there who still refuse to do the test. Still refuse, right? My good friend Vernon sitting here, right, we are campaigning to get men involved in the research. We need more men involved in the research, right? Look at those numbers, 1 in 12 Asian men, 1 in 8 white men, 1 in 4 black men. Let me tell you the truth about this cancer. It does not knock your door and says, what color are you? It doesn't knock your door and ask you how wealthy you are. What it does, if you ignore it, it will kill you. So this cancer is not just treatable, but curable if it's caught early, right? So I want you to be armed with your questions. These are the best people to give you the right answer. They're not from Dr. Google. These are the real deal here, right? So please, if you've got a question that you're concerned with, ask the panel, right? Because one, if not all of them, will have an answer. And if they don't, they will get an answer for you. Okay? Thank you.
Right, thank you, Errol. Remember, he's an MBE, this young man. Right, the next gentleman who's going to speak now is Taimur, a very good friend and a person who's really helped me out immensely with my diagnosis.
Hello. I'll stand up when I speak because I've got some slides on. Thank you, Gussy, Errol, everybody, for asking me to come and give this talk today. I've come with a team because we are a team. I'm one of the prostate cancer surgeons, one of the consultant neurologists at Imperial and at Charing Cross Hospital. But sorry, I'll stop. I can shout. I was saying we work as a team. So I'm a consultant, I'm a surgeon at Imperial, but actually we're a big team. And this is just part of it. We've got Heather, we've got Carmen as well, who are very, very senior nurses in the hospital who help take care of all of our patients. And actually probably we're about 20 plus people. If you take into account all the admin people as well that are involved, 30, 40 people who actually help run the entire prostate cancer service. So it's a pleasure to be here today to give this talk. And it's going to just be an overview about prostate cancer, and it's going to be a bit of an overview about some of the facts, but also some of the treatments that we can offer and what's changed over the years. I think many of you will know this. Prostate cancer is a leading cause of death amongst men. And if we don't, we need to spread the message on this. It actually overtook breast cancer deaths some time ago. And as we've all mentioned, the risk for just anyone walking in through the door is about 1 in 8. But for black men, it's actually even higher. It's about 1 in 4. And also, it's a disease of aging, unfortunately. We have got high-profile cases of young people who have prostate cancer, people in their 40s. But generally speaking, it's a disease of aging. So as you get older, the chance of you having prostate cancer increases. And this means that someone in their 60s or 70s is actually the most likely age to come to me and say, don't I have prostate cancer? So we have to remember that. And actually, just because you're getting older doesn't mean you should not get tested. But there are some other risk factors as well, and family history is really important. I was at this event probably 6 months ago, maybe last year, and there was a lady who stood up and said, well, my brothers have prostate cancer. I've got family members who've got breast cancer. And she was describing all of these members of her family with cancers that are all actually related. Prostate cancer, breast cancer, they're all related. And actually, if you have a positive family history, and let's say you're black, your risk is not 1 in 4. It's much higher. It might be lower than 1 in 2. So I think you've got to take family history seriously. But actually, there's a few other things that can also play a part. So having a very healthy lifestyle has actually shown to improve outcomes from prostate cancer. And actually, people who are unfit, people who are overweight, people who have diabetes actually tend to get slightly higher risk prostate cancer as well. So there's something to be said about having a general healthy lifestyle. And then the other groups that are actually at risk, there is massive geographical variation in who gets prostate cancer. And what I have to say is, when I saw this data, I was really impressed at the work that we've been doing in London, or events such as this, all of this engagement. Because actually, we know that geography plays a part, but actually in London, we have the lowest rates of advanced disease. And it's because of things like this. People are getting the word out, the knowledge out. But actually, this is not the case in the rest of the country. There are lots of places that have really poor outcomes. If we look at Scotland, 35% of their men, so 1 in 3 people who gets diagnosed with prostate cancer has it at a late or advanced stage. So we do need to keep spreading the message. And this is probably my most important slide. It's the elephant in the room. PSA is a very simple blood test. It gets a lot of bad press. It is still the first step into getting a diagnosis, or maybe not getting a diagnosis of prostate cancer. It is actually, in my opinion, a very, very good test. If you walk in through the door and have a PSA that is less than 1, I could tell you with a lot of confidence that your chance of dying from prostate cancer in your lifetime is tiny. It is minimal. But if you come in with a PSA of over 20, 99 out of 100 men in front of me will have prostate cancer. So it is a good test. The reason people say it isn't a good test is because it goes up for other things. It goes up as we get older. It goes up as our prostate gets bigger. Sometimes people with infections will present with a high PSA, but that's not enough of a reason not to have it. Because actually, if it is raised, then it means that my colleagues, all of us can do further tests to at least say, or try and find out if you do or don't have underlying cancer. And this is the second biggest myth. And I think Gussy and Errol have picked up on this, about symptoms. You do not need to have symptoms to have cancer, and most of the patients we pick up do not have symptoms. If you have symptoms, there'll be 2 reasons. One, it'll be because your prostate's enlarged. And the reason we associate enlarged prostate with urinary symptoms and prostate cancer is because that's actually how we often see men. They're walking through the door saying, oh, look, I'm having problems peeing. So I said, do you want a PSA test? And that's how we catch them. But actually, most men with early prostate cancer will have no symptoms. The ones who will have symptoms from prostate cancer, we picked up way too late. They're right at the other end. They're the ones where the cancer is spread. It might have gone into bone, it might have gone somewhere else in the body. They're going to come in with symptoms, and that's just too late. So we can't wait for symptoms. And this is what's going to happen to you when you're walking through the door. Most of you will have a normal PSA. So if you walk in and have a PSA test done, 9 out of 10 of you will walk out the door and say, all done, that's it. I'll have another one in a year or 2. Only 1 in 10 men will probably have a raised PSA. And this is what we used to do. This is what everyone thinks we still do. We have given up examining people's prostates because we know it's just nowhere near as accurate as what we now do is an MRI scan. Every single man walking in with a raised PSA will get an MRI scan. And even that's not too scary. I mean, it's a bit claustrophobic in there sometimes. It sounds like someone's banging a spanner in a drum. But actually, half of people who have an MRI are negative. So again, we say, thank you for coming, goodbye. Just keep an eye on your PSA in a year's time, or 6 months, whatever we recommend. Half, though, will have a positive MRI, and they will go on to have biopsy. But if you look at these numbers, it means 1 out of every 20 men who has a PSA test done will end up having a biopsy. Most will not. So getting that first, there's nothing, you don't have to be scared about getting that first test done. The chances are you won't need anything else after that. You would have at least reassured yourself that you probably don't have anything serious going on. And I like showing these slides because it shows you, and we're talking about research, and I've got a slide about research at the end, but all of the developments that I talk about have come through all the research that's been done, not only at Imperial, other centres in London, across the country, across the world. That's how we've carried on improving things for men who might have prostate cancer. And these scans are what probably most of you will have heard of. CT scan, CAT scan. That's the picture on your left. The prostate is that thing in the middle, that blob, that grey blob. You can't really see it very well, and you can't say anything about it. And this is the ultrasound. This is the test that we used to do to diagnose cancer. You can't really see anything on it. You just, again, see this grey picture. This is all we had available to us. This is why you used to have these biopsies through the back passage. We couldn't see anything. We were just randomly putting a needle in and hoping for the best. But this all changed with MRI. Same patient, that's the change in their scan. I'll move over to show you. You can now see detail within the prostate. You couldn't see this before. But more importantly, The reason we can say whether you do or don't have cancer based on your MRI is because we can see areas that might come back as cancer. And if you don't see these areas, we can be relatively confident. But remember, no test is perfect, unfortunately, but we can be relatively confident that actually we can let you go home and say that you don't need anything else. But if we see a dark patch, we will normally recommend you have a biopsy. And even our ways of doing biopsies have changed. They're still not the most comfortable thing. I'm not going to pretend they are, but they are much more palatable than they used to be. And it's not just a standard biopsy. We've got a lot of technology that's been developed around it. We're able to take that MRI scan. We're able to create a 3D picture of it. And we're able to then put a needle exactly where that dark spot was, because we can now see it, rather than randomly trying to put a needle and then hope we hit it. There's been a lot of things that have changed over the last 5 to 10 years. And one of the biggest changes that's happened is that we now understand prostate cancer better. This is what it looks like under a microscope. And we have essentially what I call a traffic light system of prostate cancer. We didn't have this before. Whatever cancer you had before, you got the same treatment. It was surgery, if you were fit, ended up being open surgery usually. Some men had radiotherapy, which used to be much more toxic than it is now. And the others were just told to just monitor their PSA. It was called watchful waiting. And that was it. That was essentially what was done in the past. We now understand the cancer better. We know that some cancers need to be treated quickly, more aggressively. We know that some cancers can be very safely watched. And the reason that's important, because if you're talking about the best treatment you can give someone, it's the treatment that minimizes harm, but makes sure they still have a normal life expectancy. They don't die from that cancer. And that, in some patients, is no treatment. It's surveillance, it's follow-up, it's very careful monitoring. It's nothing to be scared of. We will keep an eye on you, and if you need treatment, we will recommend it. And our treatment options have changed as well. As I said, we used to do open surgery. We now do robotic surgery. I did 2 earlier today. It's completely changed how patients recover from an operation to remove their prostate. People used to stay in a week. They used to need blood transfusions. All of my patients go home the next day. The 2 that I did today will be walking out of hospital tomorrow. They will have a catheter, and Heather will go through some of the things after surgery with you. But actually, they recover really well. I don't remember the last patient who had a blood transfusion. And actually, a lot of the side effects we talk about with surgery, the incontinence, it's still there, unfortunately, but it is better. The operation is much more controlled, much more reproducible. And so some men, unfortunately, will leak, about 1 in 10 long term, but many will regain continence. Erections, if we can save them, if we can save the nerves, then actually there's a much better chance now of getting erections back by having a robotic operation than what we used to do, just because we can see things so much better. And the one thing I like telling patients is a robot isn't an autonomous being. It's not some sort of machine that is just doing the whole operation and I sit there and watch. It's like having a remote control car. You can either push the car around or I can use a controller. I'm using a controller to control the robot. The surgeons are doing the operations. So we're always in control. And the same with radiotherapy. It's just got better and better. We used to do 3 months of it. Then we went down to 2 months. And we've now got to the point where we might be able to do it in 5 days. And it's getting more and more and more targeted, which means the side effects you get. Radiotherapy tends to cause a lot more bowel problems, a lot more problems with your back passage, having to open your bowels more often, diarrhea. These sort of symptoms are getting better and better. It does cause some bladder issues, some probably similar numbers as with surgery, but again, all of these things have been developed over time and through research. And then a bit that I'll talk about, and Heather will talk about a bit later as well, probably the biggest thing that I think has changed in prostate cancer is that we've had those 2 treatments, we've kept improving them, but we've also started offering newer treatments for patients with prostate cancer. And these really do minimize side effects. So if you have cancer on one side of the prostate, and it's a medium grade, or what we call an intermediate grade prostate cancer, there is no need to have your prostate removed. There is no need to have radiotherapy. We can target just that area. We can either freeze it, we can heat it. There's now something called nanoknife, which is a form of electricity. There are ways to just kill that area of cancer. And the benefit is, and I said 1 in 10 might leak urine. With this, it's 1 in 100, probably less. And almost no one leaks when the catheter first comes out. And erections in most are preserved. But not everybody is suitable. It's more suitable for patients who we pick up early. So again, it's the key to getting diagnosed early. You get more options. If you get picked up late, we have to be more aggressive. So this is one of the newest treatments that we're offering at the moment. And it means we can actually give you an option. It's not just come in, hello sir, have this, which they do in other cancers still. You don't get many options. In prostate cancer, probably the biggest thing I now hear is my patients ask me, how can you help me choose, or how can I choose what to have? Because often I will give them 3 or 4 options. But at least we have options, whereas previously we didn't have many. And we know some men do badly, unfortunately. Some men will die from prostate cancer. But actually, if picked up early and treated, actually more than 9 out of 10 men will probably still be alive in 10 years' time, and probably still alive in 15 years' time. So if you're 50, 60, it's not that you're going to suddenly disappear. You'll be here for a very long time after. So that's the one thing we said. You'll still be here.
Is that, sorry, can I just say, is that after the cancer, or is that still what?
That is after the diagnosis of cancer.
So you've still got it then?
No, some will have had treated. So either removal or focal therapy or radiotherapy. Some will be monitored.
What I'm asking is, can it last for that 10, 15 years? Because you said some men.
So there are some men who present late. So unfortunately, the problems with cancers is they don't behave always how we want them to. So there are some cancers that, for whatever reason, do not behave like everybody else. So that 1 in 10 patient that I see will unfortunately get spread of cancer at some point. Either they'll come in through the door and they'll have cancer that's already spread, or they'll have spread after I've treated them. Now that in itself is not a death sentence. I've not presented this today, but we've got better and better at treating cancer that spread. So about half of men will live at least 6 to 7 years after being diagnosed with spread of cancer. That means half will actually live longer.
Can it be contained continuously throughout life?
Yeah, so for this 9 out of 10, most will have had it contained. Some may have a relapse, but not all relapses need to be treated. If you get a relapse at 55, it's very different if you get one at 80, because some of them we can monitor. So it depends what the situation is at the time. Yeah, so in many, that might be the only treatment you ever get. In some, particularly the higher risk ones, you might need to have more than one treatment. And so I warn all my high risk patients, and there are plenty of them, unfortunately, that you may need more than one treatment to get it under control. Any questions there? Because I've got 1 or 2 final slides, and they're just to kind of emphasize the research point. And the reason I bring this up is because we're a big hospital, but we're also attached to one of the biggest universities in the world. And our primary aim is to take care of patients, and our secondary aim is to try and make things better for patients. And we can only do that through our research that we do. And it's not about being a guinea pig. There are very few patients who are truly guinea pigs in this sort of setting. And it's actually often very, very small changes that we do. We might call it a study, we might call it a trial, we might call it research, but often it's very small changes that I'll show in the next slide that can potentially make real big differences to someone's care. And we will offer it. So please don't be scared of it or worried about being a guinea pig or in a trial. Ask us more about it. Because actually, these are some of the things we're doing, and I could write pages on the things we've currently got going, but I just wanted to highlight how simple it is. Can I shorten the time you spend in an MRI scanner from 45 minutes to 15 minutes? That's one of the studies that we're trying to do. The reason it has to be done on a study because I don't know if that is as good as the long scan. I know it probably is, otherwise I wouldn't offer it to you. But I need to actually ask you to do it. I need your consent to do it. I can't just do it. I need to ask you to agree for me to do it, and then I need to be able to collect your data afterwards. And that's what it means to be part of a study. Similar things. Can I change the way we do our prostate biopsy? Very simple study. Can I use MRI in patients who are on surveillance for prostate cancer? Again, very simple study. Some men will have more scans, some men will have less. And the less is what we normally do. I want to know whether I can do more. So I need to collect this data. What about, you were talking about men whose cancer returns or spreads. Well, what if I give them extra treatments? Does that make a difference? How can I understand the biology of the cancer better? Well, I need to look at that cancer in a microscope. I need to send it to the lab where there's trained people who know how to understand it. But I can't just do that without asking you first. I have to say, do you mind if I take your biopsies or take an extra biopsy, extra sample at the time, and send it to the lab? So, which is why we need you to take part, because actually I can't do any of this without you agreeing for me to do it. And then this big one at the bottom. Can we screen?
I want to make a valid point about the question that's just been asked, right? What's important here, guys, is that we have to be involved in this to make this work, right? Because the professionals are still trying to find ways to make this situation a lot more easier than what it is, right? And they can't do that without the help of each and every one of you. So this is so important, and these questions are questions that they have to face every day, right? We need to be involved in what's going on, right? Because the question keeps getting asked, what causes prostate problems in the first place? Why is it so high in a particular race of people? The answer will lie with the information that these guys will collate and put together so that they can give it back to us. So very important. If you've got a question, do not shy away from asking, all right?
And the last thing I want to say is that you will all probably start to hear about this, and I'll come back to your question. We are about to launch one of the biggest screening studies in the world in the UK called Transform. And if you're asked to take part, please take part. This is the only way, or one of probably going to be one of the most important ways for us to be able to bring wholesale screening into the UK, not with what we used to do, but with newer techniques such as MRI scanning. The study is asking, can we replace what we used to do with MRI? And with a very fast, very short MRI. And many men, hundreds of thousands of men are going to be asked to take part. So if you get that call, please try and get involved.
Thank you, Taimur. Thank you very much on that. Right. Just to touch on that, it's not about being a guinea pig. It's all about making a difference for the future now, to find out exactly how we can contain this.
Sorry, you used the word, what is the norm in terms of PSA level? I don't know what the level is in the first place to say it's normal or not normal.
I'm just going to give you one number because the medical community is great. We keep changing the goalposts all the time. The number is 3. That's the number if I have to give you one number, it's 3. Yeah. So if you have a PSA above 3, maybe have a chat with someone about it. The reason we keep moving the goalposts is because actually, as I said, as you get older, your prostate gets bigger, your PSA goes up. So naturally, as you get older, your PSA is going to slowly rise. And what we tend to do is to adjust the PSA value for your age. But for a man over 50, it's 3. That's the number, but there's other numbers as well in that range.
And then the surveillance active level, as it were, what level in terms of would you be monitoring it for that period of time? What level would you consider that needs monitoring as opposed to actual surgery?
So surveillance is partly based on PSA. I'd normally want patients with a PSA less than 10, but it doesn't have to be. I have patients on surveillance with PSAs higher. Surveillance is often based on what the biopsy showed, so how aggressive that cancer looks under a microscope. If it looks less aggressive, then I'm more comfortable saying, look, I can watch this for a while, and what the MRI looks like. If the MRI looks particularly worrying, I might not recommend surveillance. But if the MRI isn't too bad, it's not a big cancer on the MRI, I might recommend surveillance. And then everything is personalized to the patient. How do you come off surveillance? If that PSA rises, that by itself isn't an indication to me that you need to have some treatment. It's an indication that something's changing. And I need to look a bit harder at why. Could it be your prostate's getting bigger? Could it be you've got an infection? Or is it that the cancer is growing? And that will then trigger a set of tests, which will usually be another MRI scan actually, to see has that cancer changed. It occasionally may end up being another biopsy. So there isn't a set value. If it starts to get very high, obviously over 20, I would start to worry. But normally, you will have had more tests before you get there. So let's say you start at 6. I'm not going to say, I want to do something to you when it gets to 7.5. I'm going to say, if it rises, depends how fast it does, but if it starts to rise, I will normally do another scan. And then we'll make a decision together on whether we should or shouldn't have treatment. I am still very reluctant to treat low-risk prostate cancer. The reason being is that the chances of dying from it are very, very small. And actually, there is a lot of data that says that low-risk prostate cancer may never, ever spread. The problem is, am I certain that you only have low-risk prostate cancer in your prostate? Could there be something else sitting there? And the answer is I'm not. But generally speaking, if all I have found is low-risk cancer, I'm very reluctant to offer treatment because treatment will have side effects. Doesn't matter what treatment I give you. And my aim here is to actually have you live a normal life, but actually without side effects and a good quality of life. So normally I will do more scans. I may even recommend more biopsies. I remember every patient I've ever operated on with low-risk prostate cancer. There was something different about that patient. Almost everyone else, we've repeated the biopsy to show the cancer is more aggressive. Does that make sense? A long answer, but...
It makes sense, but as you said earlier on, technique is changing as we speak, as it were. And what was given to me, as it were, 4 years ago is completely different from what they will be offered now. So in terms of focal theory, as it were, in terms of looking at it now and going to a specific area, will minimise the side effects in terms of the recovery period and everything else. That is just information that's good to be out there so people have more of an informed choice.
We're trying our best. So again, I'll come back to the research thing again, because in medicine we have to be able to offer you something we know that's going to work. It takes a very long time for us to get enough data to be able to confidently give you some numbers. Focal therapy has been going on for about 10 years. We're about to give our 10-year outcomes, basically publish them in scientific journals to say this is what we have found. We've treated thousands of men in the UK with it. So we've now got a lot of confidence in recommending it to patients. Other centres will start to pick this up. So in London, there's a few. There's us at Imperial. There's University College London down in the centre. But there aren't many others that do it at the moment. There's others around the country slowly expanding. So Southampton have been there for a long time. Basingstoke. But Bath just opened up, which is brilliant. Norwich have just opened up. And Northampton have just opened up. So people are now starting to set up a focal therapy service. And I think you will start to hear more about it over the next few years. Because I know up north they're all trying. Because they often email us saying, can you help set this up for us? Sheffield, Bradford, Liverpool, Manchester, Stockport, Glasgow, Edinburgh. All of these places are saying, can we set up a service? So I think you will hear about it, but it does take time, unfortunately, in anything medical.
Thank you, Taimur. We're going to try and leave the questions a bit later on once we get the panel to have a speak first. Before we go into that, there's some water and there's some sandwiches just behind the counter if you'd like some of those as well. Yeah, Heather?
I'm going to pass on to Heather. Probably should just shout.
Hello everyone, thank you for inviting me. I've done several of those sessions in the past and I'm always proud and honored to be part of raising awareness for prostate cancer screening and getting men and their partners to get involved in prostate cancer screening. So my background is nursing. I did cancer nursing and now I do the biopsy and I also do lots of other diagnostic tests. So I wanted to talk to you about what to expect when you come in for treatment. And the treatment I'm talking to you about is cryotherapy, focal therapy. And that's one of the many treatments you can have. And Mr. Shah talked about the active surveillance and robotic surgery. So I'll talk to you about, and this presentation is given to men every 2 weeks in our cancer charity at Maggie's. So if any one of you have been part of focal therapy, you would have seen this presentation. So part of my job is to educate men, patients and their family, their wives, and it's done as a webinar where I do it for all over the country. So you can sit at home, you can be on your mobile phone, and I will actually present this to you so you know exactly what to expect. So focal therapy is offered to men with high risk to low risk prostate cancer, and there's the HIFU, which is the ultrasound wave inserted into, ultrasound is inserted into the rectum. Oops, sorry. Sorry, it's meant to be a video that shows it, but anyway. Okay. Okay, so HIFU, so you have heat, so we divide focal therapy in 3 groups: heat, ice, and electricity. So I'll talk to you about HIFU, which is a heated treatment, and is usually offered for men based on the location of the cancer. So the most important thing to remember with those 3 treatments, they offer cancer control and curative intent. So one is not superior to the other, is basically the location of the tumor. So once a diagnosis is made and you've had your biopsy, your surgeon will offer you one of the treatment. And there's the ice rods where ice balls grows into, a rod is inserted into the scrotum and it grows an ice ball. Into the perineum, and it grows an ice ball, right? Sorry, I'm talking, and there's a surgeon who does it. Important. So yes, and the idea is that the ice, the temperature is brought down to minus 24 degrees, and it destroys the cancer cells. The next treatment is the electricity, which is called nanoknife, or you may hear it's called IRE. And that's where it works by electrical impulses. Again, it destroys the cancer cells, and the idea, there's minimal damage to the surrounding cells. So when you come in for focal therapy, it's a day procedure, so you come in the morning and you go home in the afternoon. And often you can walk out of the hospital and get into the car. We always ask that you have someone to escort you home because you have a general anesthetic. I had a man who came last week, and he came from Sheffield, and he had his treatment in the morning, and he took the train home in the afternoon with his wife. So it's a day procedure. And most of the time you go home in the afternoon. So when you come in for the treatment, we give you very practical advice. So it's not lots of medical advice, but practical advice. And the advice that we say to men is that if you're the sole carer for pets and you're coming in for treatment, because you may not remember those details, because you're dealing with the emotional burden of cancer. So if you're the sole carer for pets and you're coming in for surgery, we say to you, make sure you have provision at home to look after your pets. And if you don't have a wife to cook and you live alone, we advise you to make sure you have nutritious meals prepared in advance. So if you've got family or you do your own meal prep, just ensure that you have meals at home. So we talk about nutrition because we all know about nutrition is important for healing after surgery. We also talk about things like what trousers to wear after treatment. So very practical advice that you may not think of, and you need someone like me and Carmen to tell you about it. So what I say to men is that when you're going home, have joggers, make sure they're dark color, they're not white trousers or tight fitted jeans, because you'll have a catheter in, and there's lots of jelly with a catheter, and for your journey home, you get lots of water, which looks like urine, And you may not think of that, but we think about it for you, and we give you those advice. And we talk about hydration. Hydration is very important. 2 to 2.5 liters a day. In hot weathers, a bit more. We really recommend that you reduce your coffee, tea, caffeine, alcohol intake. We do advise you, if you come in for surgery, to avoid alcohol for at least 48 hours before the surgery. And also, we talk about general anesthesia. You've seen lots of shows on TV, medical shows, and you see patients having general anesthetic, but we don't assume that you know everything. So we say to you that general anesthetic means you be asleep for up to 3 hours for HIFU, a bit shorter for cryo, and even shorter for a nanoknife, and that you spend some time in recovery. After the anesthetic, you may feel a bit groggy, and you may not remember a lot of things that we would tell you after the anesthetic. And that's why when we do those workshops, before you come in, you can actually think about what to expect. Because if any one of us had an anesthetic, and you have a nurse saying, "Mr. Smith, you got a catheter in," you would not remember that, because all you're thinking, oh, what just happened? Is the cancer being treated? Am I being cured? What's happening with work? What's happening with my family at home? What's happening with my pets? So we tell you about those things in advance. And we do pre-assessment, which is like a pre-anesthetic check. And sometimes for men who come from as far as Scotland, we can do this remotely. So we try to reduce the amount of visits to hospitals, because we know most of us are working and you have to deal with cancer treatment, appointments, and we are all concerned about the financial impact of cancer, which we'll talk about later. And so we take everything into consideration if you were to be diagnosed with prostate cancer and coming in for treatment. So here at Charing Cross, we limit the amount of visits, and we also take into consideration what job you have and whether you can engage with us during work and what happens after your treatment. So this is all about the anesthetic and what happens when you come into hospitals. We have towels, and I mentioned about the baggy fitted trousers, which is very important for men when they've got a catheter in, that it helps with mobility. So going home after surgery, we talk about you go home, you'll have lots of medication, and the importance of taking the medication, because a lot of us, including myself, when you've had treatment and you have no symptoms, you think, oh, I don't need the medication. So what people like myself tell you, do take the painkillers, don't wait for you to have pain, because it's easier to treat pain once you've taken all the medication that we've asked you to, especially after surgery. If you wait till the pain comes, it's harder to keep it under control. And you'll be given lots of laxatives. Laxatives is important after general anesthetic, because we know it's the last part of the body that wakes up. And we talk about catheters, because men and catheter do not go well. And I'll explain to you. Women, we cope better with catheters, but men, it's a no-no. So I'll talk to you about catheters. It's very important that after any prostate treatment, you'll have a catheter. And that's because the prostate behaves like a pufferfish after you've treated. It blows up and it says, I am not going to help you to pass urine. So we put a catheter in to help you to pass urine, because it's important that your bladder works. It's very important. So you will have a catheter, but the good news is not for long. So after focal therapy, you'll have the catheter in for maybe about 10 days. It could be 6 days, slightly shorter. But catheters is something you have for a very short time. You don't have to get used to it, but you certainly need to get to know it. You need to get to be friendly with it, and you do need to look after it. And so the image on the screen is what a catheter looks like, and usually after 48 hours, we give you a valve. It's like a tap, and you can empty your bladder. And we do encourage you to walk around after treatment. So walking around is very important. We encourage you to walk every day, walk around. If you're watching TV, immediately after your treatment, we say after every commercial break, just make a circle around your living room. So we talk about the importance of mobility. So again, very practical advice. And the catheters, they do have some risk of infection. We don't see it quite a lot because we do lots of education to patients. And we tell you how to look after it and how to keep it clean and when to change the bag. And we do give you lots of support in terms of our telephone numbers. So we don't see lots of infection, but at the same time, we do not ignore it. We'd like to tell you about it. And so this slide is a bit scary. I'm not going to talk too much about it. When things do go wrong, we like to mention it, but not to frighten you. So it's the equivalent of, getting in a car and using all your safety mechanism, strapping your seatbelt on and make sure you follow the speed limit, follow the rules of the road, and you'll be fine, you'll be safe. It's the same thing with catheters. We tell you what to expect, but there are potential for things to go wrong, but we'll give you advice on how to reduce it. So that's the best day after treatment, is when you're having your catheter removed. It's sometimes called trial without catheter. And again, we bring you back to Charing Cross, and if you don't live close to Charing Cross, so we have patients from Norwick Park come for treatment. You can have it done locally because we want to reduce the amount of travel. And that's when your catheter is removed. You're happy to go home without your catheter, and we teach you how to maintain very good bladder health. And cranberry juice is very good for bladder health, except if you're taking blood thinners. Just be careful. You can't have cranberry juice. Constipation, and that's purely due to the surgery, the anesthetic. So we teach you about, again, healthy eating, taking laxatives, and keeping mobile. So all this is just general health to keep you healthy after your treatment and get you back to normal daily activity. So I'll pass you on to Carmen, because if we're going to talk about the prostate, we need to talk about erectile dysfunction and how we how we treat it and manage it.
Thank you, Heather.
Hello, my name is Carmen. I am a urology andrology specialist nurse at the Charing Cross Hospital, and I will just talk about erectile dysfunction. We know as well this intervention on prostate leads towards this kind of I've got already patients on. So yes, it is a side effect after this kind of a surgery. Less after the focal surgery, or more and yeah, after the radical prostatectomy, might be a little bit more to work with it. Of course, after the focal surgery, why? Because the potential lesion, it is targeted and it's not involved all the prostate. So the rest of the prostate, which is not under treatment, is pristine, and the chance to recover, it is quite good. Within 6 to 8 weeks post the surgery, you should be having a retaken function. Of course, there are interventions to be given, such as pills, such as oral medication in form of Viagra, which everybody knows about, or Cialis, which is tadalafil. This prescription, they are given by us or by GP, or initiated by us in a clinic and continued by the GP. But of course, with any kind of a medication, there are some side effects of it. Not everybody tolerates, or tolerates a bit better one than another, or tolerate bit less for beginning when you start taking, but kind of get used to it. which is headache, vomiting, indigestion, flushing, like flushing on a face, dizziness sometimes, back pain, but they are, as I said, they can be stopped or pain can be diminished. Yeah, if the oral medication stop working or is not helpful, there are some other steps which we can take and to help you to have a good quality of life. They are like vacuum pump. Probably everybody heard about the vacuum pump. Any kind of prostate surgery will need probably to have a training on vacuum pump. The vacuum pump, it is in there to preserve the penile length, girth, and oxygenate some fresh blood from the main body. And if that, it's kind of a good friend for life, the vacuum pump. There come some other steps that can be taken in form of alprostadil cream, urethral cream, which can help, as well as Muse and penile injections as well, which they're quite efficient after what my patient telling me. And of course, the last procedure that will be penile implant, which is kind of stage end of erectile dysfunction, because it's kind of trying to replace the penile tissue, basically, as in a rods. That's it, yeah? Thank you.
Thank you very much, Carmen. Well, those are some of the questions and things that people are afraid to ask, and she kind of broke them down so you can find out the little bits about those kind of things like that. Up next, we're going to have Professor Frank. Are you ready?
So good evening, all. Good evening. It's wonderful to be here. I've had a busy clinic in Royal London Hospital in Whitechapel, and I was so tired come 5:30. I thought, am I going to go all the way to Wembley and Brent? And I thought, well, if I don't, this man, Errol McKeller, will be on my case. So I drove very slowly and carefully to get here tonight. You're welcome, Errol. So, Frank Chingegwundoh, I'm a consultant urologist. I work at Barts Health in East London. So I work at Newham, Barts Hospital, the Royal London, and Whipps Cross. I've been a consultant now for 29 years. And in that time, I've really kind of majored in prostate cancer. Now, one of the things that I noticed when I first came to the East End, well, getting on to 30 years ago, isn't it? I was seeing a lot of black men with prostate cancer, more than I would have expected, bearing in mind the population in that area at the time. So I thought to myself, it's strange, why am I seeing so many black men with prostate cancer? Okay, is there any data on it? So I rang up the Office of National Statistics and said, how many black men have got prostate cancer? And they said, we have no idea. No one has collected that data. No one has done the work. And so that led me to do a study in the East End where I got all the diagnoses of prostate cancer for the last 5 years. So I'm talking about 1996, 1997 at the time. I went to the pathology lab and I said, can I have a list of all those diagnoses of prostate cancer for the last 5 years? So they gave me a long list, hundreds of men who'd been diagnosed. And then I said, well, how many of these men are white? How many are Asian? By Asian meaning Pakistani, Indian, or Bangladesh. How many are black, whether African or from the Caribbean? And the lab had no idea because that data wasn't collected. So I went to the hospital records to see, can I tell from the hospital records someone's ethnicity? That data wasn't available. So what my team did was to basically ring up all these men, ring up all these men and determine their ethnicity. So we were able to look at all these hundreds of cancers and work out whether these men are black or Asian or white, those broad categories. And then it turned out that actually being black, your risk of getting prostate cancer was double if you're white. And that's where this, the data comes from. So I published that data in 1996 to show that actually black men have an increased risk of getting prostate cancer. Now, looking across at the States, so I linked up with researchers in the States, and it turned out it was also the same. So in America, the American black man's rate of prostate cancer is double the white men, and with the Asian men, it's much lower. And then a group of us researchers got together and did a bigger study. So rather than hundreds of men, we looked at thousands of men, and we were able to prove that actually nationally something about being black gives you that increased risk of prostate cancer. And the question was, why? What is it about being black? What is it about being black that increases your risk? And 20 years later, we still actually don't have the definitive answer. One of the interesting things is that if you go back, and we published a paper on this in 2009, if you go back to the transatlantic slave trade, and you look at where those men were taken from the west coast of Africa, from Nigeria, Ghana, Liberia, Sierra Leone, and so on, and you look at where those men ended up in the Caribbean, in America, Brazil, in the UK, that is where you get the highest rates of prostate cancer. So it's something about the West African diaspora, something about the West African heritage that gives you that increased risk. Why? We still haven't determined that. There's a lot of research going on in West Africa, in America, some here as well, looking at various genes to see, is it related to our genes? Is it related to our diets? Is it related to the gut bacteria that we're carrying? But we still don't know the answer to that question. Now, so because we don't know the answer to that question, it's important that the black community realizes that there are increased risk and then therefore do something about it. Because that knowledge wasn't really widespread, that black men are at increased risk, what we found happening was when a black man went to the GP asking to have a PSA blood test, they were being turned away. And so one of the things that a lot of us have been doing over the last 20 years is trying to raise awareness in the community in that you are entitled to get a PSA blood test. The other observation that I made was I was finding a lot of black men that get their prostate cancer diagnosis and tell nobody. They'd keep it to themselves, which was a disaster, because one of the things that's been alluded to is that there's a strong family element to prostate cancer. So if your father has prostate cancer, your risk as the son is doubled. If you've got your father and your uncle and another brother with prostate cancer, your risk is quadrupled. Now, if you don't know your family history, you wouldn't know that you're at increased risk, and you wouldn't know that you should start getting yourself tested perhaps by starting at age 40 if you have a family history. The other importance of the family history, which Taimur also referenced, was that if there's breast cancer or ovarian cancer on the mother's side, you as the son, your risk of prostate cancer is greater than, say, one of your friends where there's no family history of breast cancer. So it's so important that we don't keep these things to ourselves. We share our family histories with our offspring. And I think that is improving. I remember as a child, an aunt would pass away, and I'd say to my parents, what was wrong with her? Or what was wrong with him? We don't know. Or an aunt would suddenly disappear. I hadn't seen her for months and months. And I'd say, well, where is Aunt so-and-so? Oh, she died. What? Cancer. Why? When? So that kind of lack of sharing does us no good whatsoever. So, you know, one of my roles is chairman of a charity based in Brent, actually. It's called Cancer Black Care. Some of you may have had some support from that charity. One of the things that Cancer Black Care has been doing over the years is trying to reduce the stigma that people feel because they have a cancer diagnosis. Many people isolate themselves and cut themselves off, so we bring people together. And in fact, on Saturday, we're taking well, maybe about 80 or 90 people down to the seaside, bringing people together and their families to, you know, to share, you know, a positive experience. So please share your family histories. The other thing that I want to mention is this research, which again Taimur has covered very well. It's so important that we are involved in research, because when the drugs are developed that will help us, if we're not part of those trials, we don't know if those drugs will work for us. So when it comes to blood pressure, for example, certain tablets do not work in black people for blood pressure. So the tablets that you would prescribe would be different. It's taken many, many, many years, and you know, for that to be found out, because black people were not taking part in these studies. So we were being given these drugs that weren't actually going to be effective. So it's important to take part in these studies, so when the drugs are launched, we know if they're going to work for us. The other thing about research is that people who are in clinical trials do better and live longer than those not in trials. A, because they're having the most advanced drugs, but also they're being followed up very, very, very closely indeed. So please, I must emphasize the message, if you're given the opportunity to take part in a clinical trial, then please do so. So there's so much more that one could say about the whole area, but I think I would rather answer questions than carry on talking to you. I think all of us would, yeah. And we have a GP in the audience who can perhaps talk about things from the GP perspective. You know, I don't blame the GPs, because some of the education has not been the best in terms of PSA and the risk in black men. So GPs often get a hard time in terms of prostate cancer. So we have Dr. Kandi Ejiofor, who's a well-regarded GP, who can perhaps talk about when, you know, what she says or what she does when a man comes to her saying, I would like to know my risk of prostate cancer. And I'm sure she's not one of these GPs that turns men down and say, don't worry about that, don't worry about that. And also, before I pass over the mic, the rectal examination. Many, many, many men have not gone to the doctors with urinary problems or worries about prostate cancer because they don't want a finger put into their bottoms. Now, apart from, you know, manning up, it's actually, I think Taimur said as well, it's actually not necessary now. The blood tests and the MRIs, they're far more informative than a rectal examination. So you don't need to be scared to go to the doctor because of what they might do to you. It'll just be a blood test.
Yeah, my question's around lifestyle changes. What kind of lifestyle changes can you make? So I'm thinking along the lines of, you haven't been diagnosed, you don't eat healthy, and then say you don't get diagnosed. So what can you do in terms of diet and things like that, and exercise?
Yes, I think again, I think Taimur alluded to this. Yes, you can take this one.
I'll stand up. So I think generally, diet, exercise, healthy lifestyle is important, because actually, regardless of what happens with your prostate cancer, that's probably what's going to decide how long you live. Ultimately, how healthy you are, what your weight is. The reason it's never clear on what advice someone should follow for prostate cancer or prostate health is because there's lots of things out there, but no one thing suddenly will magically change your kind of condition. What you need to do is to cut down on animal fats. That's important. You need to try and cut down on sugary foods. You need to try and control diabetes. You need to get your weight down. There is some evidence vitamin D helps. Actually, vitamin D seems to be the magical cure for everything at the moment, but there is some evidence it helps with prostate cancer. There's some evidence that some vegetables and antioxidants might also help. This is why this thing about tomatoes and cooked tomatoes used to exist, lycopenes. You can also, there's now some emerging evidence about phytoestrogens, soya products. There are some foods that potentially might be good for prostate health as well. So it's not just about following one thing. It's about taking all these little things together, and what that means ultimately is a lifestyle change. Someone who eats less meat, someone who exercises more, someone who gets more sunshine, someone who takes some vitamins. That's not a prostate-specific program. That's a life-specific program. And that's what I generally recommend.
Yeah. Final question I was going to ask was about cranberry juice. I think someone mentioned that if you have prostate, you shouldn't drink cranberry juice.
Not for prostate cancer. For infections, potentially, there can be some benefit. The actual tablets are much better than juice. You actually probably will give yourself diabetes with the amount of sugar you will drink in cranberry juice to get the required number of nutrients. The tablets are better. But yes, there's no harm in having it. Again, it's about balance. If all you drank was cranberry juice, you wouldn't be very healthy. But if you have a glass or two of cranberry juice, it's not going to do you any harm. It might make you better.
We're going to do the questions in a minute. I just wanted to add to what the guys were saying, right? When I was diagnosed with this cancer, right, I went to my dad and I said, Dad, I've been diagnosed with prostate cancer. My dad looked at me and he said, boy, I had that 5 years ago. And let me tell you, whatever he had, he took it to his grave with him, right? For about 10 years, me and my brothers tried to have a conversation with him and he refused to have the conversation. And this, I was so upset with this, right? I found it very hard to speak to him until I started doing this campaign. And what Frank is saying and Taimur is saying is exactly the case. We need to know what's going on in our family. You know, I just wanted to say something quickly. My grandson asked me the question. He said, Granddad, why are we not talking about this in schools? Right? He said, they're talking about periods for girls in schools. Why are we not talking about this in schools? And I said, I haven't got an answer for that question. So he went to his school, right? He asked the teacher did nothing about it. He went above the teacher and he went to the headmaster, right? The headmaster phoned my house. My wife said, the headmaster for Louis' school is on the phone. He wants to talk to you. I said, I'm not his father. I'm his grandfather, right? So I got on the phone to him and he said, Mr. McKeller, your grandson has brought up an issue, right? He's gone above the teacher and he's come to me and I actually agree and support him in this conversation. So what I'd like you to do is come to the school and talk to the kids in assembly with their parents. No problem, right? And let me tell you this quickly, right? If you think as adults this is a difficult audience, when you're talking to 12-year-old kids, let me tell you, right? This little boy put his hand up, and they're very polite. Sir? I said, yes, young man. He said, I've got a big willy, and when I grow up, I want to have a bigger willy. So how do I make sure I don't have this problem? Right? Now, you can imagine how difficult that was. Exactly, Mum. I know. I'm glad you done that. Right? So I said, I had to think about the answer because these kids are on. These kids are switched on. We all brought up see I'm blind, hear and deaf, right? These kids, right? Let me tell you, right? I looked at him and I said, young man, I want you to work hard at school and become a doctor and find a cure for this problem. The kid looked at me and he said, yes, sir, I think I'm going to do that because when I grow up, I want to have a bigger willy. Right. Now, listen, and I know we've got to laugh at it, but listen, we do not want to have this conversation 20 years from now, right? That's the importance of that conversation, right? The kids' parents came up and apologized to me, right, because I could see them going bright red when this... Listen, children are asking questions, and that's what's important, and that's why the medical world needs your help. If we don't talk about the illnesses that are in our family, how do we know? It's very, very important. So please.
Thank you very much, Errol. All right, we've got another 2 more speakers, and then we're going to go to the question and answers. Sorry? Yeah. Right, we're going to have Well, Kandi, right. We're going to have Dr. Kandi. She is a GP in Brent.
Hi, good evening, everyone. My name is Dr. Kandi. I am a GP in Brent and Harrow. I would actually first start with a very random meeting I had with this young boy this morning. Yeah. So he plays football with my son, and halfway through, is it you? Yeah. Halfway through, you got a nosebleed, and I had to help you stop your nosebleed. Do you remember? That was just a few hours ago. What happened? And that just shows how important it is in terms of community and supporting each other. And just, my role as a GP, he remembers me now, I can see it. I was holding your nose for the best part of 20 minutes, but it just shows the importance. And I'm really happy to see younger members in the audience today. I do think that with prostate cancer, we often focus on the slightly older, older community. But it's really important, as they've said, that we start discussing, having these conversations. I would love to come to an event like this where we see 20 and 30-year-old men who are understanding the importance of taking their health really seriously, and that I can see that conversations are happening. I'm sure all of you have, brothers, sons, nephews, etc. So it's just really important to spread that message and encourage them to come with you, because this isn't something that is just starts and stops with you. As Mr. Chingegwundoh said, it's generational, right? Family history really impacts us. So it's really important that we start having that conversation. I also wanted to mention, kind of on what you were saying in terms of prevention, as a GP, it's so, so, so important. It's so important that you think about your health. I think it's often, especially when you're in a room full of surgeons, they talk a lot more about the surgical aspects and, the bits and bobs, but a GP, for me, it's really important that you take your health so seriously, that you advocate for yourself, that you understand what's important. When Errol said, there's water and biscuits at the back, I was expecting everyone to go up and get a bottle of water, because we have to stay hydrated. We need to be drinking plenty. I've got my bottle here, and I'm always carrying it with me. Not Coke, not fizzy drinks, not processed food, burgers, not alcohol, not smoke. There are so many things that I could go on and on and on. And it's not just food, it's your lifestyle. How much sunshine are you getting in the day? How well are you sleeping? How active are you? Are you sitting for more than 6 hours a day? Because that also, negatively affects your outcome. So there are so many aspects of your health that if you don't start, and I always say, I came late today, so better late than never is what I say. So it's never too late for you guys to start taking care of your health, thinking about what you can do differently, even if it's just one small thing. It makes a massive, it's a compounding thing, a butterfly effect, as it were. You don't know how big that effect is later on down the line, but it's a small thing that will make a massive difference, hopefully. I also wanted to mention that as a GP, so recently I started putting on some more community events at my GP practice, which is in Harrow. And I tried to do a Black, an African and Caribbean health event on a Saturday. I took time, made posters, text every single person who fell into that demographic. I was so excited. I woke up so early that morning. I was like, woo, going to speak to my community today. And one person showed up. One person. And I was like, why? Why is it? And then the next week we did an Asian event. The week after, we were doing an Eastern European event. But the Asian event was full. Full. Out the door, brim round the corner, boom. My event, I just kept on being, and they were like, I was like, let's go again. They were like, no, it's not worth the resources. And I was like, no, we need to find a different way. Maybe the text, maybe it's too early, but at the end of the day, there's only so much that we can continue to do. We need you guys to come forward. We need you guys to establish a relationship with your GPs, because other communities are establishing a relationship with their GPs. GPs are still really, really, really important in the community. So please don't feel afraid to just make an appointment, have a conversation. It's 10 minutes. 10 minutes in the wider scheme of things isn't much time. Just take that appointment. utilize it, ask what you want, put yourself first, and just ask whatever questions, however big or small. Trust me, other people do it. I have people talk to me about their cats. I have people talk to me about going on holiday and, you know, all these other things before they even get to their health. I'm happy to have a conversation, as Errol rightly said. I don't mind, and I don't think any of your GPs mind, just so that we can establish a relationship, so that we can build that rapport, so that if something does happen, God forbid, you are a little bit more likely to engage. You are a little bit more likely to ask questions. We can catch it sooner. We can support you in your care and your aftercare and going forward. So it's so, so important that you just think about those things and reach out. And actually, on Errol's point... Yes?
A lot of communication with surgeries now seems to be through these apps, you know, at the moment it's patches, and you've got to fill out the form online, send in your whatever's troubling you. How do you go from there to get in a conversation with
them? So that's a really good question, and I would say that because there's a wider political, you know, governmental issue with 10-minute appointments, lack of GPs, and just not enough access to care, which is just a huge issue, I would encourage you guys to really take some time out to try and overcome that technology. Technology is a increasingly, you know, onerous but important part of our lives, and we utilize technology to just try and manage the sheer amount of patients and care that we have to, and I don't see that changing. So I know that we preferred it the old way. Even I preferred it the old way. When I'm accessing it for my 3 kids and my husband and everyone else, I preferred it the old way, but things are changing. So we just have to get used to these patches, these text messages, AccuRx, eConsult, you know, whatever system it is that your GPs are using. Yes, yes, yes. Try not to let the technology be a barrier for you accessing care. As I said, everyone else, other communities are doing it, and they're just kind of getting on with it. They're utilizing their, you know, families and friends and neighbors, etc. I just don't want to see us, you know, continue to kind of, you know, drop behind, essentially, on every hurdle, because we already have, like, cultural difficulties in terms of how we feel about doctors and healthcare, and we don't trust the institutions, and now they've brought in technology, and there's another hurdle for us to, you know, and then if we talk about medicines, then people say, no, I want to do my soursop, and I'm going back to Jamaica, and this, and it's true, but these are things that we have to talk about. Even if that's your belief, that's absolutely fine, but we have to have a relationship. We have to discuss it together.
I just wanted to know, seeing that you are a general doctor of the area, if somebody does come in and ask for a PSA test, how quick would that materialise, or what process would they be put through before they actually get the test?
In all honesty, if you make it to the door, from my perspective, obviously I'm very well versed, and hopefully you guys are too, so you can advocate for yourselves, because that's the most important thing. You might get another doctor who isn't as well versed on issues in the black community, and then you have to talk a bit more. But for me, as soon as I converse with you, you say, this is what I want, I'm worried about this, or I have a family history of this, that's it, let's book a blood test.
The doctor did say that in the past people were turned away. So
yes, yes. But I think people are becoming a bit more aware, but the point is, if you come in for a blood test, as you would for a full blood count, if you're feeling a bit tired, or an HbA1c, if you're worried about diabetes, if you're worried about prostate, you fall within the... You can, of course. This is advocacy. This is advocacy, yeah.
Listen, I have this argument with doctors all the time. I'm their worst enemy, right? Because they ask me, why do I want people to be checked every year? I'm an ex-mechanic, so everyone who drives a car in here, I have to MOT your car. So what's the difference? So I'm glad we've got doctors who actually care, right? But she's one. I was just wondering what. No, there's many doctors. There's many doctors. Yeah. I mean, listen, Patricia will tell you, we're taking this campaign on doctors to a point, right, where you, Frank has said it, Taimur said it, and his team has said it. This is your right, ladies and gentlemen. And let's make this clear. You have a right to go and have this test. When you go there, you don't have to be rude, right? Because they expect you to raise your voice, and when you raise your voice, it's a problem. If you do not leave until you get access.
But Errol, sometimes it's a challenge, especially for men, to go into the doctors and say, can I get a PSA, and they say no, and then you're trying to advocate, it's quite difficult.
Sorry, remember, a doctor is generally a general practitioner.
A GP.
Right, that's their program. So if they specialise in what this bottle does, that's fine, right? But it needs somebody like these guys here, when you go in there, right, that will be sympathetic to what you are asking for, right? But when you get there, do not walk away at the first point, because the doctor will ask you, why do you need this test?
Exactly. Right? People feel challenged and they think, oh, do you know what, actually I'll just leave it. Which I was going to say that I think a pop-up, and if we did have a few doctors and black nurses that represented ethnics, you would probably get more of a crowd. And, people coming in and asking questions, as opposed to going to your...
But still important, when you go to your doctor, go there with the intention of getting this done, right? Listen, they can put you off as much as they like. It is your right to have this test.
So is it annually, or is it 2 years? Every year.
I think it's, I say every year.
Every year. Can I just add to that? I've been through what you did, right through, and actually I go to, I just said the hospitals around here, because that's another story, and because I misdiagnosed me, and when they found out I had aggressive cancer, so I was told by a guy named Errol Blacker, I don't know if you guys he's in the, right, so he said, just don't just leave the hospital straight away. They misdiagnosed me, I've got a year and a half. Right? I don't really want to go into it but basically you've got to know is that you've got to be careful, you've got to take on your responsibility yourself and don't take what the doctors say, just so. Question it. Because I was going there and I just went to the doctor, my doctor, ordinarily, I was having a urine problem. And she said, just, give me a sample. Right, come back the next day, you've got a problem, I'm going to give you these, take this prescription, and I should get rid of this problem you've got there. By the way, do you have any, she just said, do you have any problems with cancer or prostate? Wait, where are you going with this? No, not at all. She said, I'd like to do a PSA test on you at the same time. Well, so I don't know what made her do that, what made her ask you the question. And it was this was in 2022, 3 years ago. Okay? That's when the pandemic was going on. Anyway, she took the blood sample and it was high, 20 or something like that. She said, right, I'm going to make an appointment with the hospital. I'm not going to say the one, but it's not Park Royal, and it's the other one that's around it. Right, because they made me sign to say I wouldn't disclose this, and I've not mentioned their name. So I'll leave it to you. Anyway, I went there and she stated that I should have a scan, an MRI scan, because she did the test with me, the finger and that. It's my own doctor. That's why she referred me to the hospital. They then took the MRI scan, and the next week they called me back 3 weeks later and said, we've got the scan done. There's a shadow on your prostate, there's a shadow on your bladder. We're going to give you, we don't know what it is. That's right, I said, when you say shadow, what is it? What's a shadow? What is a shadow? Well, we can't really say, but we'll give you continue taking the tablets for your urine, what you take, because it looks as though that shadow's going down. Okay, 6 months, come back, another MRI scan, and we're the shadow on your bladder seems to have almost gone. The one on your prostate is still there, but I think it's getting smaller. It's like, I think so. Yeah, but you're thinking, but do you know what it is? No, I don't know, but with my experience, doing this a long time, my experience, I know that is not cancerous. I know that is not cancerous. Okay. Another 6 months, he said to me, take another 6 months, it should be okay. Right. 6 months on, this now, in all, it's about a year now, year and some, including with the doctor, got my general practitioner. Come back, another MRI scan, and he said, well, it's still there, but it seems as if it's done. You know, I suggest you go another 6 months. I said, yes, but do you know what it is? He said, no, but in my experience, I know it's not cancerous. I said, yeah, but you know, it's not cancerous, but you don't know what it is. And it's in my prostate. But it's not outside the prostate, but nothing outside. So, you know, just carry on. He says, is there anything that we could do? Sit here if you want. We can have a biopsy. I said, yeah, let's have a biopsy. He said, well, look, this is a pandemic time and there's no stuff. He said, can you make it to Park Royal Hospital? They've got the theatre vacant on a Sunday morning. So I said, yeah, all right, I'll get there. He was there, and we got he used the operating as well, and he did the biopsy, and I understand what you're talking about. That is horrible, yeah? The nurses were standing there as if they knew what was going to happen. They said, look, I put my hand, one give me one hand, and said, squeeze when you're ready. And then we start doing this thing. I think I'd like if I'm having a baby, you know what we want. And he started saying, squeeze, and I squeeze, you know? Anyway, they did, and he heard it click, and then Tommy click, he's taking a bit of skin, you know? It must be about 4 or 5. I can't remember sending you this, Professor, thanks for that, I remember coming to see you. Anyway, the next day, he said, we'll have the results for you in a week or so. You know, he said, yeah, all right. I said, all right. It's the same one who was telling me, you ain't got nothing wrong. He did the actual biopsy. So he said, well, we'll do the results. That was the Sunday. The Monday, they phoned me up. The Monday, I said, could you come in Tuesday morning early? I said, yeah. For what? The results. All right, so I'll come in. And he said, I said, where's the doctor? Where's this stuff? He said he couldn't make it. He couldn't make it, so he asked if I could step in. I said, yeah, all right, okay. So what's the problem? He said, what's the bad news? No, we have good news and bad news. I said, well, what's the good news? He said, no, you haven't got cancer, it hasn't gone into your body. I said, what's the bad news? He said, you have got cancer, right? You have got it, but not only have you got it, it is aggressive. I said, what do you mean by that? He said, it's Gleason 4 plus 5. He said, Gleason 10 is the highest. You've got 4 plus 5, so you've got Gleason 9. I said, well, what's that? He said, anytime that come outside that prostate and catch your body, it starts running straight through. So I said, well, what? He said, you've got 2 options. He said, the operation or the chemotherapy. I said, well, you know, he said, with chemotherapy, you know, it takes over a period of time and such and such. He said, with the operation, they cut away the prostate, and but the other things you have was it EC or erectile dysfunction, and yes, went through that, and they were right. So anyway, I had was the robotic breathing surgery. Robotic keyhole. And this was at Guy's Hospital, right? right? Because he told me the guy that, so Mum, you leave that hospital and go to Guy's, because that's where he went. And he went there, and in fact, he said if you could get a chance to see Professor Frank Chingegwundoh, so I had to look him up and Google him and find out he was near Whitechapel up that side there. But anyway, I made an appointment to see him. And I don't think he could remember. But he said, because I wanted him to do the operation, but he said I've stopped doing operation now for the last 2 years or 3 years. He said his section do it. So I said, okay, anyway. I said, well, we have to, I might go to Guys, and he said, Guys is also a good hospital. So I really wanted him to do it because I hear he's got such a good record. But yes, basically, sorry for taking so much time, but you know, what you've got to do is take your life into your hands, you know, take the authority, what they're using, and question it. You know, it depends on how you feel. You're not happy. Say you're not happy. Don't feel as if you're being overruled because of their profession. You know how you feel, but you should question it.
Can I say something? Do you mind? Just say, just want to first say sorry that the NHS hasn't treated you that well, but I'm glad you got there in the end. But I think you've got 3 really big points, is that we need to take ownership of our own health, because actually if we don't take care of it, no one else will. We can't rely on other people to tell us what to do all the time, so that's really important. And second, I think you said, if you're not happy with the information you're getting, go somewhere else. Go find someone who does have that information, because you shouldn't have to tolerate not being given the correct information. And the third thing is really important. You can go anywhere you want to have treatment. Guys is a fantastic centre. There's others. You can go anywhere you want, and you've got the right to choose. Just like you have the right to have a PSA, you have the right to go anywhere you want. Pick the centre.
The Guy's Hospital, they have a walk-in clinic there. That's useful, right? I think that's a Tuesday or a Friday. So you've got to phone them up and have your national health number with you to make sure they can check that you're generally. Okay, but that they do have
say something about that. That service at Guy's walk-in needs to be available to anybody. They've restricted it now. Only people who live in Lambeth and Suffolk. And the reason why they've done that is because some of the other boroughs would contribute towards Guy's. Because Guy's Hospital is actually 2 hospitals. Because they've got Guy's Hospital, I'm not talking symptoms, I'm talking the Guy's Cancer Centre, which is just as big as the hospital, which is on London Bridge. So what I will say to anybody is, you're entitled to ask for a PSA. If your doctor refuses, just say to him or her politely, can you just send me an email and put that in writing? So, you lower your voice, and that gets the end result. I just want to go back to something someone said earlier. My dad got prostate cancer in 1994. He's one of the Whitrush generation. He decided in 93 to go back to Jamaica, and he had a blood test at King's College Hospital in Canberra. We got the result of the blood test, which was done in February, 7 months after he had it, courtesy of the Royal Mail, which said he had a PSA of 22. My dad at the time decided he'd had enough of Thatcher in Britain 42 years ago, and he spent the whole of his pension money on having Hargreaves, who were the top, it was a Jewish firm in Jamaica, they were the top medical consultants, and they did the open surgery. It was 8 hours, it was 5 consultants who did it. You didn't have to get the cut you open, the stitches from here down to his crown jewels, and he lived for another 31 years. Now, I got prostate cancer 10 years ago,
I had 28 years notice. But other than, when my dad had prostate cancer, he told me and my full brother. My uncles, who followed my dad going to Jamaica, had prostate cancer. They were a little bit cuter. They came back here, they had the operation, rest up with us for a little while, and then went back to the Right? Now, like Errol has mentioned, my name is John Licorish. I'm a highly region, and I've been involved in PPI. If people don't understand what that means, it's NHS, so patient participation, involvement and engagement. I started off doing it at St. George's Hospital when I had a radical prostatectomy done by Matthew Kelly. He introduced me to another doctor who asked me, could you be a rep at Guy's as well, because we don't have any reps at Guy's. So I left St. George's because they didn't have a problem there recruiting black men, and I was at Guy's for 5 years. We made a film promoting prostate cancer awareness. During 2022, you can go on to YouTube. I made it with the actor Colin McFarlane and Evan Russell, who is the founder of the Man-to-Man, Brother-to-Brother prostate cancer support groups. Guy's Hospital has actually got 4 specific prostate cancer support groups, but there is one specifically for black men. After having my radical prostatectomy 10 years ago, my dad died, went to Jamaica to bury him, I don't know what it is, discussed, came back out of PSA, 0.7. Huge panic, St. George's Hospital. Matthew said, hang on. We've just given you an MRI scan, there's a little bit of prostate in the pelvic area, we're going to have to refer you to master. So during COVID, I had 32 sessions of external beam radiotherapy, low dosage in the pelvic area. Because, and I'm going to say it quite openly, because I was also a rep for Guy's, patient contributor for Guy's, and St. George's Hospital. They treat me like I'm some celebrity there. Then, after I had my 32 sessions of external beam radiotherapy, I continued to work for Guy's, and then in October last year, I ran into Dr. Vincent Q at Victoria. I tried to dodge him. He said, why are you doing all these videos and getting all these awards for Guy's Hospital? And we need you here at the Masters. We're the ones who saved your life. So I resigned from Guy's at Christmas. They were thoroughly disappointed. The chief exec said to me, why are you leaving? Don't you like us anymore? I just told him straight up, I'm joining the Masters. He said, what? I said, well, when the number 1 cancer hospital approaches you, you can't say no, can you? So, I've been with the Masters since January. Dr. Alison Tree said to me, Vernon, you do so much good work for us, because I'm on a lot of their committees and research study groups. We'd like you to put your name down to be a patient governor. I said, Alison, without being disrespectful, I go to Errol McKeller Prostate Cancer Support Group. I'm a member of the South East Cancer Health Centre in Croydon Prostate Cancer Support Group. With Errol, I've been with him for 5 years. With that group, I've been with him for 10 years. I was recommended to join them by oncologist Dr. Baba John. I'm a PPI representative for King's College London. I'm a PPI representative for Imperial College. I'm on the follow-on study group with Professor Rakesh here. I'm also involved in the Royal Master with Alison Tree. So I said to me, the doctor, we'd like to see a government, we don't have any black men representation. I said, okay, so there's a couple of women there who do British breast cancer. I said, okay. I said, how many people? I said, there's 12. I thought, I'm not going to nobody knows. I got 58% of the votes. Yeah? Now, what I will always say to people is, one of the other reasons why I got involved in PCI is when I was a rep at St. George's, in Croydon alone, if they did 1,000 blood tests, at least a fifth, 200 people would have a PSA of actually 6 or more. And of that 20%, 75% of the people diagnosed prostate cancer are of African or Caribbean heritage, right? The amount of men who got diagnosed disappeared. This is after the biopsy. This is known people, right? And they said, would you mind sitting in the nurses doing interviews? And I would say to them, listen, just get the treatment. And the thing that I found, which was a unique selling point, is I told them how much my dad paid. It wasn't even the health, it was the money. I said, if he was in Jamaica, this is a £60,000 operation. And guess what? You don't know who you get. I'm not saying, because not everybody can afford Hargreaves. There are a lot of doctors, I don't want to be disingenuous, but there are a lot of people out there who, let's just say they haven't been vetted. Yeah? I said, if you're in America, and this happened to my cousin, Errol McKeller in 2004, he was a partner in the firm, he got diagnosed with prostate cancer, he went to his insurance company, and the first thing they said to him is, how much is the operation? He said, 120,000. Well, we'll pay 50,000, but we capture the insurance. He had to give up his job as a partner, sell his shares, take a job as a manager, downsize his house. His house he used to have in the back garden. He's the only member of my family who had a swimming pool in the back garden in Miami, Florida. He had to downsize and relocate to Chicago. And you realize Americans are more keen up about their health because they pay for it. We have this thing in our head, NHS is free. It's not free. And let me just say quite openly, when I had my radical prostatectomy 10 years ago at St. George's, the cost of the whole procedure is $72,000. I saw it because I asked for it under freedom of information. The external radiotherapy sessions I had at the Royal Marsden, the 35 sessions, that's another $48,000. If I was in America and I own property, I'd have to probably sell it and become home or rent. So what I'm saying to us is, and take it from me, I've met a lot of the herbalist guys, you know, the well-known stations I call them, and I get the dirty looks when I go to Ruby Road Market, or Brixton Market, or Tooting, they know who I am. And I always say to people, look, you get diagnosed with prostate cancer, because I get the phone calls 2 years, or an email 18 months later, on stage 3. And I'm thinking, well, what do you expect them to do? Because you're past the stage of having an operation which they will do radiotherapy. They can put you on hormone treatment, but you know, once it's spread to your liver, or your organs, it's a completely different game. And all I'm saying to us is, and I'm going to be honest with you, I find a lot of the younger generation force their grandparents to get treatment and fathers to get treatment. And this is what I like now. The entity has changed. It's moved from the wife to the son saying, hang on a second, Dad, you've got prostate cancer, you have to do something now. Because the son's saying, well, you might be ready to go, but we're not ready to go. So, and I hate to say, it brings out the worst in black men if you challenge them about their health. Because they have this thing about their sexual organs. You can't tell me to have an operation that's going to end my sexual life. And I always say to them, well, if you continue how you are, your sexual life ain't going to last for 3 years. So it's up to you.
Just say, oh, hello. Just to say one last thing, actually, and I'll be really, really quick because I'm mindful of the time, is that everyone I know, even myself, I lost someone really close to me from kidney cancer last year, and everyone I know has had some sort of bad experience with the NHS. And I'm not knocking the NHS at all, but I say that more to say that you just have to keep pushing. The system isn't perfect, but you just have to keep pushing to find the answers and get through it. And don't let a bad experience or a bad doctor or a bad hospital stop you from getting the care that you need, or a bad GP practice, because you can always move your GP practice, but just don't let that stop you from getting the care that you need. That's the last thing I'll say.
Thank you very much, Dr. Kandi. Thank you, Vernon, for that experience. So thank you very much for that. We got Dr. John Licorish here, who's a public health consultant for Brent Council.
Yeah, it's been really, really good. For those who don't know me, I'm John Licorish. I'm Public Health Consultant, Deputy Director of Public Health in Brent. My responsibility is to look after the health of people in Brent. And those who know I do a lot of this outreach and discussion. It's really pleasing I didn't have to talk today. It was really nice just sitting listening to such informed people in front of me and such esteemed colleagues beside me. Because those when I love to talk, I don't need to talk today. So I'm really, really very pleased. I'm very pleased that everyone's here today. Such an important topic. Just to echo what colleagues were saying, yeah? Everyone knows they talk a lot about trust and all that stuff. If you're not happy, you can go and find another doctor. There's always another GP practice. There's always another one. And as you say, you ask, and you ask again, and you ask again. It happens to me too, and I'm a doctor. So it's not unique, yeah? Never write the system off. But you can get the care that you need. It's interesting, I did a session at a temple, and I asked everyone one of the questions, what's your experience like with regard to primary care? And they said, it's fine. And they said, you just have to be a bit pushy, but it's fine. So if they can get that, and they were in Brainton Harrow, we can get that too. But sometimes you have to be a bit pushy, and you have to ask, and you have to ask. And if you need to change your practice, then you change your practice. But never be denied the care that you're entitled to. I'm going to talk briefly because most of what I said has been covered, but everyone familiar with this was the man van? This is why I brought here the man van, which was doing mental health checks. I would like to bring it back at some point in time, but all of that is a work in progress. We're just going to talk a bit about cancer because we don't prostate cancer, but bear in mind there are other cancers, yes? And we need to, because we're talking about family histories of cancers. Just be aware, if women have breast cancer, men chances are you may well have a risk of cancer. But please remember there are many cancers. Does everyone know about screening? Yeah, we screen. For some cancers we screen. We don't screen for prostate cancer. And Prof. Frank was discussing that. You know, that's something that we should have. You know, my colleagues would say there's no evidence, there's not enough evidence to have a screening program. Well, that's because we never did the studies, we never did the research. Yeah, that's the reason why there's not enough evidence. You know, the volume of evidence from the US and Europe and everyone's looking at saying we should have a targeted program. The only question is as Taimur says, what do we do with screening? Whether we use an MRI, the different modalities, but we should be doing something. Why? Because we can intervene early, we can determine if they're aggressive or not, and we can determine which cancer we can do something about. So therefore, all my public health colleagues will talk about the criteria. There are criteria to do it. We just need to be bold enough to take the research that my colleagues here are doing and act on it. And that requires a bit of will, which is often lacking when it comes to the NHS. Everyone who knows when I talk a lot about inequalities, inequalities means a difference in health, yeah? We know we're not all the same health, yeah? We have lots of issues. We're here to talk about prostates. We know about the inequalities in prostate, but the inequalities right across the system. If we look at prevention, we take less, ladies will be aware of this, we're less likely to take part in cervical screening. Why is that? Ladies? Scared, it's painful, they will say, yes? We're less likely to take part in breast screening. We have a bowel screening. Those of you who are over 55, you should have had something through the door about the bowel screening. Everyone knows about bowel screening? Did you send it back? Yes. Yeah, that's good, yeah? We're less likely to take part in screening. Why is that important? Because the earlier we find the cancers that colleagues here have been pointing out, that's when they can do the magical things that they can do. When we diagnose late down the road, what we can do is very little. So that's why we really will, at these various stages, prevention is better, screening, and if not screening, early diagnosis. Early diagnosis is, as my colleagues here is saying, is knowing yourself. If something is wrong, try and get something done about it. Speak to someone, ask again. There are always colleagues. You've got 10 minutes, as Dr. Kandi has said, use those 10 minutes, yeah? But get some advice. Why? Because if we wait and we wait and we wait, I go back to my experience, those of you who know me now, with COVID, when people were walking straight into A&E and going straight into intensive care units because they were waiting, yeah? If we wait, we'll be going into stage 4 or some sort of terminal stage where we can't do anything else. So don't think, don't debate, wait. Get something done. There's lots of advice now. Now, if you go back 10, 15 years, it wasn't there. The work that Errol and colleagues are doing, that work can be done right across the board, cancer, black care, and I can go on and on. There's a lot more advice now than there was, and a lot of it's tailored to us. So we need to make use of it. We've also got inequalities in terms of treatment outcomes. Our outcomes are worse, and that's across the board in most cancers, yeah? And that's why often because we've got choices, we've got a modality of choices. So we're getting diagnosed, and then we're running away, getting cars, driving away, doing all sorts of things, yeah? I was with my grandfather, he was diagnosed, and he said, well, I left the hospital, and did you go back? No, John, I didn't go back. Why not? So so let that be a lesson, yeah? And that's one of the reasons why we get inequality to treatment outcomes, because even if we're getting diagnosed, we're not getting treatment, or we're taking a long time to go back. So have those conversations. Have more conversations. If you're not getting any advice, you have more conversations. Get a different consultant if you need to be, yeah? We've got very good consultants. Most of us will listen, but never be put aside. Cancer affects you in many ways, yes? And my colleagues talk about the physical aspects, but as I call the psychosocial things, we know about the physical things, we'll tell you all about the side effects. But it affects all parts of you, and Errol and Gussy have talked about this. It's the social aspects, the loss of work, home for 6 months. The economic hardships that could cause. We were talking with the colleagues in America. I have a friend of mine had an operation for gynecological cancer. Cost her £30,000, £40,000. She had to sell a car to do it. So we're lucky in that regard. The change in relationships, a colleague talked about that, wife leaving, the impact on sexuality and fertility. That is hard, but sometimes it's better to be alive and have a life than have a not brilliant sexual life. And there's much that colleagues will point out to. There's a lot we can do now to mitigate against things that were happening before. The psychological aspects, and that's something that was often not talked about. Fear, anxiety, distress. We're big men, we big up, we don't bother. We large and in charge, but we're not. These things bother us, and they affect us, and they affect all of the people around us. So we need to be aware of these things. Have talk, have conversations, listen, yeah? If you need professional help, get professional help, yeah? Talk to wise men who've been through it already, who can tell you what to do. But these things happen, and we tend to brush them aside and ignore them and say, they're not important, yeah? All of these causes, and there's the spiritual aspects, yeah? That's really important. We need to think about these things, how they impact on us. This loss of hope, the uncertainty. So all of these things will affect you, yeah? So we need to think long and hard about these things, because it's not just the physical things and disease and the getting the treatment and the side effects. Everyone knows me like data and numbers and whatnot, so I'm not going to talk too much about this, other than to say that part of my job is to look and see what's happening with the data. As Prof. Frank was saying, getting data for ethnicity was one of the most difficult things in the world. If one good thing COVID did was allow me to get ethnicity data. Yeah, and that ethnicity data is understanding who's getting what conditions. Because before, they would say, Dr. Licorish, 75% uptake in Brent. Very good. And we say, okay, now I can look at it and say, well, actually, it's only 30% in the Black African community, 25% in the Caribbean community, 95% in the Irish community. So now we can understand these things a little more. So it's really important. So if anyone ever asks you, what is your ethnicity in the NHS, please don't ask them why, yeah? Because I use it. If no one else uses it, I use this data, because that's how I can help to challenge my NHS colleagues in terms of getting the kind of services that you need. There's a pretty slide. I'm not going to go into any detail, but this is looking at cancer prevalence. And we see prostate cancer here. So 24% of the cancers, prostate cancers in Brent, coming from from the Caribbean community. The our population, this is the GP population, only 6%. Yeah, so we can see the 1 in 4 is coming to light, eh? So Brent's no different to anywhere else. So that's what we call this big inequality with regard to cancer data. So this is why it's important that we have this information, because this is why I can make cases to get resources for Dr. Kandi to do her work better. We can make case for our colleagues in the VCS sector to get grants. So it's really important so we know how to target the money, because the decisions are made at a national level often for a population which doesn't look like us. So we need to make clear that our populations are quite different. This is same data stuck in a different way, and it's put all of the black population together. So the 18% of the population, 30% of the prostate cancer cases. It's a bit different here because the African population has lots of Somali groups, so whose rates is not necessarily as high. But again, it's a significant abnormality. You can see there. Don't look at the numbers. Just look at the size. Just look at the size. It's big. Yeah, that's all you need to remember. It's very big. Yeah. So therefore it's there. Whether we get diagnosed or not, that number is still going to be big. The question is whether you are diagnosed early or late, but you're still going to be in this big number. And I think that if you remember nothing else I say, remember that and go and tell your friends, yeah? So this was the work we did with the man van, and hopefully we can bring the man van back again, because I thought it was a really good initiative. And again, I'm pressing my colleagues in other places to do it, because it's something that we can really use. As those who know, we have a number of vans. We do hypertension and diabetes and health checks in the community. And one of the things I want to do more of is to get this done. So I'm working hard, because it's slightly difficult, because I need to get my colleagues in secondary care involved, because we need to make sure that when we find things that we can send people places. So unfortunately, it's not as simple as we are. They have these vans some places, but we're working very hard to see if we can bring it back, because it was really very successful when we were here last time. So again, I wouldn't do that. That was just some of the data about what we're doing. So lastly, in the interest of time, so what can we do to reduce death and cancer? We talked about that earlier, about living a healthy life. Unfortunately, it's nothing specific for prostate cancer. Taimur spoke about some of the issues, but it's no magical bullet. Everyone said, what's the magical thing that you can do? There isn't. In the same way, you could look at lung cancer and say, well, actually, if you don't smoke or don't chew tobacco, your chances are going to be a lot less. Someday we may get that information. I often tell people, when I went to medical school, you had an ulcer in your stomach. They used to remove your ulcer. Then all of a sudden, we start treating with antibiotics and triple therapy. So data changes. And the way it changes is research. How are we getting involved in research? We need to be involved in research. Prof. Frank said that. We need to be involved in research. Everyone says, not man, I ain't no guinea pig, nobody testing nothing on me. That's what they say. Well, if we don't, and our people used to say that when I used to come with the vaccine, if we don't get tested, it will be tested on the people who come forward. Therefore, it will work on the people who come forward. So it's up to us to get tested. And as I always tell people, as Taimur has mentioned, when you're in a clinical trial, you'll get the best care around. Make no mistake about that. So it's an incentive for you, I actually say. So if you ever offer the chance to be in a trial, please do be in a trial, because that's how we get better care and that's how we learn things. Because when these decisions are made, and I use the example of screening, they look at what's the research and what's the evidence. And the only way we get research and evidence is by trials and studies. And trials and studies mean people agreeing. You have to agree to do it. So, and you've got to set an example to the younger people, because we've come up with a culture of not having nothing to do with research. It's been bad, and we can quote all these historic examples. That's all. That's very good, and that was the past. But we have to look forward to the future. The other thing to do is take part in screening. So ladies are here, your breast, your cervical, your bowel. We've got aortic and other screening programs. Take part in these screening programs. If you're not sure, go get some advice. Come and talk to us, come and talk to your GPs, but take part in these programs. Because remember, the earlier we get picked up, the earlier we can get the right treatment for you. Again, early diagnosis. If you think you have a problem, go to someone nice like Dr. Kandi. She will sort you out and listen. And if you don't, you go back. People say they get intimidated. Write it down on your phone. Get someone to write down on your phone. So if you need to, you can go read to the GP. I'm concerned about 1, 2, 3, 4, 5, 6. Because often you forget when you get in there, your mind gets blank because you sat in the waiting area too long. Write them down on the phone, on a piece of paper if you like, old school, so that you don't forget what it is that you want. And if you're not happy, you can always get a second opinion, or you can go somewhere else. But remember, it's your health. It's not my health, it's your health. And it's
go somewhere else. Another GP.
You can register with another Yep. Yes, it used to be quite difficult, but now it is not that difficult.
The only delay is getting your records over.
Yeah. That's what I was
One
saying,
GP
getting
to
your
another.
records
So
over.
for you to see a GP, it's not.
Or you can actually go for
Yes, you can register and then you can save it online and take it.
and then on with your records
And
follow.
then your records follow about 4 to 6 weeks.
Yeah. But that doesn't stop you being seen.
That doesn't stop.
That does stop. Yeah, so always remember that. If you're really happy with your practice, don't say, I need to suffer in silence. No, you don't. Ask around there somewhere where there's a practice where...
And you can re-register online.
And you can re-register online now. It's a lot easier. So you don't think if you really find your practices, as my uncle used to call it, I don't want to go to the quacks, you know. And I used to say, Uncle, you need to go and find another practice because there's another practice we can go to. Early discussion of treatment options. Mr. Taimur mentioned that. You need to discuss that, look it up, have a discussions, and have an ideas in your mind of what the options that there are, because now we have lots of options. Back in the day, we didn't have lots of options, but for most cancers and most treatments, particularly prostate, we have lots of options. So be informed and have those conversations. Early treatment. You get diagnosed, please don't run away. I talked about the psychosocial aspects. It's hard, it's difficult, but get some help and come back, because the earlier, remember, the block is there. And whether you run away or not, the cancer cells are doing what they're doing, yeah? So time for most things is of the essence. And have adequate follow-up. Don't disappear. And sometimes, well, the hospital didn't come back to me. We'll follow them up. Annoy the consultant, annoy his secretary, but follow them up, yeah? Make sure you get followed up, because they could have, depending on what's going on, there could be recurrences. So if you're supposed to get a follow-up and someone says that and you're not happening, check on it. If you can't get to the hospital, go back to your GP. But don't ignore it or assume everything is fine. If that's it, and be clear when you've gone, when's your next appointment. Yeah? And if you're not, please do check on it. And as I keep on saying, be involved in research, because it's ultimately, for the community's perspective, it's the most important thing. And have conversations, keep informed, which is what colleagues are here doing right now. So that for me is thank you very much.
Thank you, John. Right, I know that some of the information that you all been taking in so far might be a lot. You know, sometimes you might leave here, you might have a question and stuff like that, but now, could you please give a big hand for the panel first, because I think they've done really well, really, really well. Now, this is a time now for you to ask any panel any kind of questions that you might want, that you might feel to ask any of the panel.
I'm sorry, can I just mention one more thing?
Yes, you can.
So I wanted to mention slightly, which I think is very important, about the psychological support we offer at Charing Cross, which is at Maggie's. Macmillan offers it as well. So you can walk into the Maggie Centre, Charing Cross. You don't need an appointment. You don't need to be a patient of Charing Cross. And we run workshop for men having hormonal treatment. And we run healthy eating workshop. And we also run aromatherapy workshop. We have a personal trainer. And also I wanted to talk about, lots been mentioned about receiving a diagnosis of prostate cancer. We have the narrative. We can help you if you need to tell your wives, your sons, your dad, because sometimes you want to talk to relatives and friends, but you don't know the words. So we can help you with that. And if you walk into any charity and you can say, well, I've been diagnosed with cancer and I need to talk to my children. I had a gentleman who's his children were doing GCSEs, and he was diagnosed with cancer. And I said to him, who's at home with you? And he said, oh, my children are doing GCSEs, and I don't want to bother them. And we were able to support him in telling children, young teenagers going through hormonal changes themselves, how we can support you in the words to use. Because when you tell a young child or even a relative, and if you're the breadwinner and you're telling your wives, your husband, I've got cancer, straight away they think, oh my God, the family will be financially worse off. And there's ways you can do it and say, well, I will have treatment, I will be able to work. And also, a lot of men say to me, I cannot attend screening because I've just got a job. My manager wouldn't give me time off. And if I take time off to attend screening, I'll lose my job. There are laws in the UK. You are entitled to attend screening, and you should not have loss of earning. So we support you with that, and we can give you letters to take to your managers to say that I have an MRI scan, I have a biopsy, I need a day off the next day. So we can support you with those things. So don't think you're alone. There's lots of support here at Charing Cross, Macmillan. There's telephone support, and I'm sure this charity here will help you with the support. Your GP is also a good support in terms of telling relatives and being available for appointments for screening. Thank you.
Okay, good evening, everybody. I'm here really because of Errol McKeller. I'm Blaze, and I'm a broadcaster amongst community activists. An interview with Errol McKeller many years ago meant that I could not support him with this cause. What Gussy didn't say, though, was that before being diagnosed with cancer, he was also supporting the cause, doing the work. So thank you to Gussy. Dr. Frank Chingegwundoh brought about this research. If it was not for that research, we wouldn't have those figures. If it were not for those figures, we probably still wouldn't be listened to. Dr. Kandi's been to one of the community events. Dr. John Licorish I work with really well. What I want to encourage everybody is to understand it is your health in your hands. Your health in your hands. And sessions like this, we'd need to tell our friends, to tell their friends, to bring their friends. This place should be RAM. Because we know if it was a different event, there'd be a lot of people here. So we need to encourage more people to help the likes of Gussy and Errol to do more of these events. Just very quickly, I'm currently running a radio research project. There's been lots of talk about research today. I'm doing that with the Imperial College because of the same reasons we've spoken about today. If we don't take part in research, then they're just not going to know. If we don't challenge, there's going to be no difference. I'm also running the C Word project because, as you've heard, people from the African diaspora, we don't even mention the word, let alone talk about the illness. So I just want to thank Gussy for this evening and for him to come along with me and for me to come along with him in this journey. But you guys need to come along with him in this journey. So well done and thank you.
Nice one, Blaze. Thank you very much for that.
Hello, good evening, everybody. I'm just a little bit confused about the age of where I could go to the doctor. I mean, sorry, I've done mine, but how I started raising money for prostate cancer in January, and on my journey, a lot of people was asking me questions. I'm a part of a lot of football groups and DJ groups and stuff, and one of the questions that came out of what age is really recommended to get the PSA test. Some says 45, some says 50, so I'm a bit confused. The van was fantastic because I was one of those people who went to my GP and I said, can I have a PSA test? And they told me there's no need for me to get it. Luckily enough, Bridge Park had the man in the van, and I stopped there one day and I said, can I get my test done? And that's how I got my test done. And that's how I started my journey of trying to raise awareness for prostate cancer. So I'm currently doing a bicycle ride, 300 miles throughout the month of August, just trying to raise money for prostate cancer as well. So as I do my journey, I just want to give people more information. So that was one of the questions, really.
Thank you very much. Anyone that's got a question directly for the panel, anything at all? Well, please support this young man with a bicycle ride. We've got to do that as well.
Oh, do you want to answer? Yeah, go.
Yes, thank you. So the age, what age should you be getting your PSA tested? Now, the reason there is confusion is because the official NHS guidelines say from the age of 50. However, because black men get prostate cancer 5 years younger, if you're black, you can get that from 45. So that's kind of the kind of official thing. However, I think it should be from the age of 40 because of the numbers of men I'm seeing with prostate cancer, particularly those with a family history. So my view is from the age of 40. The official NHS guidance hasn't caught up with that yet. But I'm telling everyone in the community from the age of 40.
Can I just say one thing? I think that's where we're going to go, by the way. I think that's where we're going to end up. It's going to be from quite a young age, particularly in the high risk group. I don't want to plug an Imperial study because we've done a lot of plugging, but we're about to try and answer this exact question is, what do we need to do to find prostate cancer in 40 to 45-year-olds? Because one of the issues we have is that all the data is in an older group of men. If I put a 40-year-old through an MRI scan, it is not the same scan, or it doesn't look the same as someone who's in their 60s. The prostate's younger. It looks like a younger prostate. And so there is a little bit of work we need to do to better understand what it means to have further tests and a raised PSA at someone who's 40 to 45. But I think that is where ultimately we're going, because it's better to know and follow it up and treat when you have to than not know at all.
Okay.
That's right. That's probably because we are getting men in their 30s from all races, and the common denominator, well, we see is there's always seems to be either father or grandparent or uncle. There seems to be that correlation.
I think that's the key, really. There's some genetics that run in families, there's some genetics that run in ethnicities, and they're the really high-risk group, and they're probably the group that we need to be targeting at a younger age, because vast majority of men will actually get prostate cancer later.
Yeah, I was going to add to what Vernon just said without a microphone. Hey, Vernon. Essentially, I mean, that makes perfectly good sense, because the lady to the right said, you deal with older men coming through to have prostate diagnosis. And I know there's a sensitivity element that's involved. So there's so many things you're focused on, you don't want to do a bit of marketing with them afterwards, because the likelihood is, as Vernon said, as Errol has said, son has it, you might be dealing with son in his 50s and 60s, father potentially, or grandfather potentially had it, and possibly 30/ almost 40-year-old son is probably in the pipeline to possibly be next. So would it not be prudent to say, hey, do you have any sons? And what can we do to potentially invite you to, getting your son involved in the study? Because you've got an active member taking a Vernon, for example, then you get son. And I don't think in that circumstance where you've treated someone, you've got an element of trust, right? So they're more likely, you're more likely to be pushing against an open door. So that was one question. Well, just one point of observation, just adding to his point. And it was more for Dr. Kandi as well, because we continually hear this, and sometimes I think, I don't work in the NHS, I don't work in public service. My background is different. And my thought process is there's trends and things that you see and you hear. And we come to these events and people say, oh, you're getting turned away, oh, you're getting turned away. And Dr. Kandi doesn't look like GPs I've had in the past, because they're getting younger, right? So my thought process is, surely, this is I'm not at NHS, surely there's a bulletin that goes out to GPs. It may be a monthly bulletin, it may be a bi-monthly, it may be a 6-monthly bulletin, and it's telling you, don't forget prostate checks for men at X age. It almost makes me feel as though they have training once, they're told something once and forget about it, and it's never revisited. So isn't there a way that can be a refresher/reminder? And again, in terms of disparity, start with London, start with Birmingham, start with Manchester, start with Bristol, start with places where there's a large population of African Caribbean men. So even if those bulletins went out to those GPs, start with those sectors and then maybe push out. Respectively, we know we're saying, all right, can you spend all this money, and we're probably like 1.5, 2 million of a 55 million population. But ultimately, I'm thinking it's a more targeted approach to get the GPs knowing that we're going to come over to and have a conversation. And the last bit is because we're black, right? And it's not the same for all of us, but your 40-year-old black man can look about 29, yeah? So, sometimes I do these marketing campaigns, and Vernon, I'm going to use you as my guinea pig because I know you. They look like Vernon, or they look like Errol.
Yeah? All right, say what you will. And we don't. A 40, I know Gussy's son, and he doesn't look, he's probably knocking on 40's door, if not there already. And we don't look that way. Yeah. Well, you are, but I'm talking about your boy. So my point again is, in terms of how that marketing is, you know, we look a particular way, we may come to you and say, hey, can we do it? And you think, he's 32, you don't need this. No, he's actually 46. So it's understanding those cultural nuances from a GP perspective and how you get us. Because if I come back again in 10 years' time and men are still getting turned away, I'm saying, isn't that the easiest hurdle for the NHS to overcome?
Thank you very much. Yeah, I think this young man wanted to.
I want to answer.
He's going to answer this one first, yeah?
I'm going to push back a little bit, and I will push back to say that there is a huge, appearance bias that we have. You're right, we look younger than we are a lot of the time. But that's, how do I say it? We're pushing against a current. If you're trying to get a lot of the GPs to change their mindset. I think the more important thing is getting the community, yourselves, individuals, really advocating and showing up for yourselves. As I said, I did a community event and one person showed up, and that was targeted to every single black person in my GP practice, and only one person showed up. And I've done loads of that. Whenever I see someone who is, really struggling, obviously I do it to all my patients, but if I see someone who's really struggling, I'll reach out again. I'll reach out again and again and again. And I don't get, no, I'm too busy, can't come, I got work, So there's a lot of, I think, education that has to happen the other way in order to make the change. And I think it's more important that you guys talk, you share, we speak up, we advocate, and just don't be afraid, to say, actually, I'm not leaving, as he said, persistent, because I'm not going to push against somebody who says, I'm not leaving. I'm like, okay, I've only got 10 minutes, take the blood test. So I really do think that you should advocate more than asking GPs as a whole to change a difficult system.
Let me just add to that, because to agree with Dr. Kandi, because locally in Brent, I know there's a GP who's been involved in doing that training in terms of that to get GPs to change their minds. So we are doing that. The fact that it's not making a difference to some extent, as Kandi said, there's a tide and we have to push against it. GPs get hundreds of instructions for hundreds of different things, not to defending them, but sometimes, and some are very quick on the uptake and some are very slow. So I think it's always, I will continue to push from that point of view, of course, but I think it's more important that we push from the community's perspective, because if you're quite firm about these things, I can guarantee you will not, 99 times out of 100, you won't be told no, because they've only got 10 minutes, and they're not going to spend 10 minutes arguing with you.
I was just going to say the same thing. So I don't see secondary care in public health. I'm sitting in the hospital, but I'm part of the groups that essentially try and disseminate information out from our Cancer Alliance, which is a big group of all the hospitals in essentially North and bits of South London. And we do try and get this information out. And it's my opportunity to ask a question: does it filter through? Because we often end up making presentations and videos and slides, and they're meant to go out to the community, so I hope they are getting out. Yeah, maybe. We're trying. So the answer is we're trying. We maybe haven't got there just yet.
And everything else. So it's very hard to get them to advocate for you individually on top of everything else that's going on. That's the truth, isn't it?
Thank you. Young man, you wanted to say?
Yes, good evening, panel, and good evening, ladies and gentlemen. I'm here to tell my story. 2018, I was diagnosed with prostate cancer and went to my GP and get the information on what I'm supposed to do. So, get my operation done, and right now I'm here, kicking and well, and still fighting. So, I'm glad I take that step and deal with it before it gets even worse, So, I would, advise any men to always don't hesitate when you get anything about prostate. Just go deal with it straight away.
Thank you. We've got a few more minutes. Have we got one?
Good evening, good afternoon. I cannot believe I'm doing this myself. I am really asking for advice because I myself suffer with, well, they haven't told me it's cancer yet, but swelling prostate, which I went to see the doctor, and the doctor told me what would I like to do? Would I like to have it cut, or would I keep it? Would I like to keep it where it is? Sorry, my voice. Well, yeah, even have more issue than what it is. And so I asked him what the issue would be if I have it cut. So he told me, yes, there is issues, but he wasn't telling me what the issues would be. So I myself now I am taking treatment for prostate, for lung cancer. This is why my voice has come to the way it is, because of the medication that I am taking, where I was taking. So yeah, the panel, I don't know if the panel could give me answer, but I would like to ask, should I have the prostate cut off? Because he said that it's not cancerous, or could that create cancer?
Yes, so I think the answer to your question would require a more kind of detailed one-to-one with you. If you haven't got prostate cancer, so the prostate gland is just enlarged and it's stopping you passing your water properly, there's a lot of different options. You don't necessarily have to cut the prostate. You can inject steam into the prostate, which makes it shrink. But in order to answer your question, that would mean that would need a more in-depth discussion, one-to-one, as to what kind of symptoms you're having, what sort of trouble you're having, and what other medical conditions you have. But there's a whole range of treatments that don't necessarily involve surgery.
Okay. So well, this is something I think. I think I'll be doctor myself. I think if it's not cancerous, I will take the chance. Yes, I have to take the chance. So put it to my guidance. I'll put it in God's hand that I cope with the cancer that I got. I will treat that first before I see about down there.
Can I just say, guys, this is why we set this charity up, right? So that these are the kind of questions that we will help you with by either bringing you the specialist or asking the specialist to speak to you direct, because these are questions that need to be answered. And that's why, if you look at the panel, right, I mean, they've today, for me, I'm very proud and very honored to be sitting here, Gussy and myself, with this panel, right, because they've dealt with all the questions that have been asked, but they know there's a lot more, and we are here to help you. I mean, Gussy and myself, if you guys want us to do this again, we will do this again. Amen. Right? Amen. You've got our details, Gussy and myself. Listen, we're born in Brent. We have to make sure that what happens, right, we get it right in Brent. Although we are trying all over the country, right, we are born in Brent, and it is personal to both Gussy and myself.
Yeah, it's just to reiterate what I said before, is that do phone first. Phone up urology at Guy's Hospital and ask to put you through it and ask what days are the walk-in days for your PSA tests, because I did it myself, and there are a number of guys I know in Brent has gone to guys, and they've accepted them. You've got to have your national insurance number, just to identify who you are, right? Because I don't want you to be put off by the fact that it's only boroughs that donate money to guys, that they'll only do those borough, but it's not so, because they do Brent, yeah? And they've been I went on Monday gone for a PSA. I'm still waiting for I've got to phone them actually for the result. If it was bad, they'd phone me, so I know that. The other thing is, because everything's gone digital now and everything's going modernized, I'm one of the old timers. I don't know anything about this computer business, but what I have done, what I'm started on, is Brent are doing courses for the over 50s, our age, right? And it's held at Brent Hub at Twyford Road, or Brent in the Brent Hub in Central Square. Yeah, so you do computer courses, right? So right now I'm learning how to use the computer, because everything is online, and they're teaching you about Word and processing and emails, and so I'm going through that now with them. So it's there and it's free. Yeah. Okay, you just go and you enroll. Yeah, you go and enroll, get your information. But the thing is, so many of us are now looking into it. You've got to go there quick, get your name down. Yeah, so it's a rolling course every 6 weeks or so. Yeah. Right, to enroll, it's Twyford, is it Twyford Abbey? Twyford, where Brent Hub, one of the Brent Hub is, one of the Brent, blah, 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 blah. All right.
Yeah, look, we can share that. We can share that information. All right. Yeah, we can share that. As I said, listen, guys, I mean, look, Patricia covers a lot of information in Brent, right? We're lucky, we've got Dr. John here, who is the eyes and ears of Brent. So you have somebody that you can come to, guys. Gussy and myself, right, we are contactable. Please, everybody here, take away the information that you've got. If there's information that you need, we're here to help you get that information, right? You've got all my details. Drop me an email, right? If I can't give you the answer to the question, look at the panel, right? I will ask the panel to give you an answer to those questions. All right?
Right, I just want to say thank you once again to everyone that's taken time. I know you've all just come from work, and it's been a long day, but for you all to still be here today, give yourself a big round of applause. Yeah. Thank you very much, because the amount of people, that we've reached out to, and the ones that we know that should be here are still not here, But again, people say that it's a man thing. Yeah, it is, because men don't want to go nowhere until they're really in pain, and then when they're in pain, that's when things have gone too far. But again, I want to thank the panelists: Carmen, Heather, Taimur, John, Kandi, my cousin Errol, and Dr. Frank. Thank you very, very much for today. And I want to thank my photographer there, these two guys here. Thank you guys for taking time out to come down today. Thank you very much. And thank you guys.
One person he's forgot, and I'm going to hail him out. Stuart, please stand up and take your applause.
Is he hiding there? Is he gone?
He slipped out.
Yeah,
right.
He's actually slipped out the door.
Pastor Stuart is responsible for looking after this building, and he has always stood firm, right, in helping us to raise this massive awareness, right? So big thank you to you, Pastor.
Right, so once again, there's some information on the table. Please take it away, read it. Don't just leave it there. Just take it away, have a read.
Yeah. Okay. Eat all the food as well, please. I don't want to be taking anything away with me.
So thank you all so much once again.